Welcome to USMLE SARTI. We are committed to empowering IMGs. We're excited to guide you on your match journey. Don't forget to click subscribe and turn on notifications so you can get notified whenever we add new content. Also, follow us on Instagram and Twitter for the latest tips and tricks regarding everything USMLE. Now, let's dive into it.
Welcome everyone, welcome attendees. Today we have a very special webinar and we did get a lot of questions, how to pick a specialty, what is day in the life of a specialty, how much do you earn after a specialty, what are the career options after a specialty. So all those questions that you had asked us. So we've assembled a very illustrious panel. All of them have been a former Sarthi student in some shape or form. Many of them are now our panelists. So we will try to go by specialty, and each one of them will share their experiences, will answer questions, and hopefully make it a very productive session for you. Just a bit of housekeeping. We will take questions, but you can ask questions in chat. Just to make it more productive, I think the panelists will speak first, and then maybe after they are done, we'll take the questions. We do have many discount offers and coupons, etc., for you that you will see during this webinar, and my team Swati and others are also there in the back end, so they can answer questions as well. Very quickly, for those of you who don't know about us, USMLE Sarthi, we've been helping IMGs since the past, 8 years. And, rest of it, I think, Swati, you can share the URLs, but we do want to get started. And our first speaker, by the way, has just joined, and Dr. George Koshi. So what I request of our panelists is feel free to introduce yourselves, because I will otherwise butcher half of your credentials and names and all that. So, I'm going to go with the agenda that we had set up. First up is radiology, Dr. George Koshi. So, George, welcome, and the floor is all yours.
Thank you, Pawan. Can you all hear me?
Yes.
Perfect. Just going to share my screen. All right. Hopefully everyone can see my screen. All right, perfect. All right. I just wanted to take this time to welcome you all, everybody who's watching our webinar today. We'll be having a lot of good speakers on different topics and different specialties, and whether you've applied this year or not, it's going to be a good opportunity for you to understand how things work and what you need to expect when you're trying to get into that specialty. So without a lot of other stuff, I'm just going to move directly into my presentation. So I've been tasked to talk about my specialty, that is radiology. And I think some people have a lot of idea about radiology, but most people have significantly less idea about radiology, which is fair. So things to note: the most common tracks for radiology are your diagnostic radiology track, then you have the integrated interventional track, then some programs have integrated nuclear medicine with radiology track, then you have research tracks and educator tracks, which are also not very common, but they are present in certain programs. Traditionally, by traditional, I mean when you go from medical student to residency, that pathway for radiology is about 5 years, which includes 1 year of internal medicine, or prelim internal medicine, prelim surgery, prelim pediatrics, whatever, or a transitional year, and 4 years of radiology. So it's usually 4+1. Some programs have a categorical program where you do all 5 years of the same program, but there are many other programs that just offer an advanced program, and you have to find your prelim position at another program. The alternate pathway is unique to radiology, radiation oncology, some OB-GYN, some neurosurgery, and some general surgery programs, wherein if you have completed your residency in your home country or another country and have been practicing as an attending in that country, you may be eligible to do the alternate pathway in the US and be able to get board certified eventually and practice in that specialty. There are pros and cons to both, and I would recommend that you go through the ABR website and look for more information on all of this, because it takes such a long time to discuss all of this. The numbers I'm giving you, this is from Medscape. There's obviously a big range of like compensation after residency. So about 483 is what was this year's number. Last year was 473, so like a 10% increase. In general, if you're going into academics or at the VA, the overall pay in numbers might be less, but each has its own perks and specialty. The VA specifically gets you better pension and better perks and insurance and all that stuff. But if you're in private practice, your pay might be more, but work-life balance not so much. So there's always pros and cons. All these are separate conversations. So many different fellowships to choose from, many advanced fellowships to choose from, as you can see. And even if you're not doing a fellowship, there are many general radiologists in the country that read other multi-specialty things in their practice, whether academic or not. Very hot market right now, and a great time to be in radiology. Essentially, if you're considering radiology, things to know are radiology is a very adaptable specialty. By adaptable, I mean you can adapt to many different subspecialties. If you have an interest to just the abdomen, just the GI system, just the GU system, just the brain, you're able to develop your clinical niche and practice in that way. You have the opportunities to do procedures. You have the opportunities to just be a general radiologist and not do any additional fellowships. Opportunities to do informatics and patient contact as much as you want. And speaking of that, there's so many myths to radiology, especially in the US, that I would like to debunk. Traditionally, every question that people ask is, okay, is there a future for radiology? Is AI going to replace radiology? There's no patient contact. Why would I ever want to be in that specialty, right? There's so many myths, and this is something that unfortunately keeps getting propagated. I'm sure for the other speakers who are here, I'm sure like whether you're in internal medicine, family medicine, pediatrics, there are certain myths to that specialty that others believe, and only you know the true reality. So similarly, only when you explore the field is when you know that many of these myths are just that, they're just myths. You're never alone in a dark room all day. You interact with a lot of people, including your own co-workers. You interact with patients. You do a lot of procedures. You do a lot of talking to patients, especially if you're going into breast imaging. Every single mammogram you do, or every single study that you do that day, you typically meet the patients, talk to them, and things like that. That's just an example. What I will say in terms of AI, and that's again a whole other lecture, is AI will not replace radiologists, at least not in our lifetime, but people who do not appreciate and do not use AI as a good tool may be replaced. So that's essentially my thought, and I think that's how we're going to move forward. Another pro about radiology is the amount of time that we see patients. So I think it's a very small number, like less than 1/3 of radiologists that see patients for less than 30 hours a week. Most of them do see patients, and I think that's a good pro, especially for people who are worried about not seeing patients. Overall, the amount of time radiologists spend on paperwork, administrative work is significantly less when compared to many other specialties. Again, this is just a overall generalized statement. we talked about the good stuff, and I talk about the challenges. I think one of the most common challenge, which is not just for radiology, but for many other specialties, is difficulties in getting good reimbursement from Medicare. And this is something that your subspecialties and your the actual specialty, what do you call it, the big societies in the country are fighting with Congress and are advocating on your behalf to Congress every year to make sure your reimbursements are protected or at least increased. So this is a challenge that I feel everybody faces, including radiology. So that's that's one of the things that to look out for. These things about EHR and all that stuff, it's very common with other specialties. I don't really think it's common, I mean, unique to just radiology. I was asked to talk about this day in the life of a diagnostic radiology resident. It's fairly very simple, and this is just a couple of programs. It may vary in programs, but in general, you typically have a 7 to 8 a.m. didactic lecture or a case conference. And then you go in at 8 o'clock to your reading room, and then you read cases. This is a regular diagnostic rotation, so you read cases. And then 12:30 to 1, you actually have a lunch break. I know many other clinical specialties are envying this right now. So you actually have a lunch break. And then there's some didactic lecture and other case conference, again, between 1 to 2. And 2 to 5, we typically read cases. Nobody typically stays beyond 5 unless you're the call team or anything like that. But typically you're in a fixed working hour schedule, which is pretty neat. Now, say you are in another rotation where your fluoroscopy or interventional or breast imaging, all this is part of radiology. Just replace read cases with, you see inpatient consults, you do procedures, and you read the relevant imaging. So in addition to just reading, you see those patients and do those procedures. And I think that's how it's different, the other subspecialties. And remember, I think this is common across many specialties, and most of your protected time, at least for didactics and case conference, they're always usually protected. And so that means like you don't have any clinical responsibilities at that time. And I think that's pretty good. So moving on to this last section, and this is, I think, where most of the questions are typically. A lot of people want to know, what can I do other than, like, once I do radiology, can I do something else? And there are many other opportunities. There are opportunities for you to go into leadership, like in the societies. There's opportunities for you to do dedicated research, or there are a couple of radiologists that consult for different industries. So you could do any of those things. And consulting for industries does, it's a very viable career. You can earn upwards of 200, 300, up to like $1 million a year just by consulting different companies. So these are very viable other options that you could do if you didn't want to continue doing clinical radiology. Work-life balance in general is pretty high. Which means that the amount of burnout is also relatively less. Typically, we have people switching over from other clinical specialties into radiology, not so much the other way around. So I've seen very few radiology residents moving into specialties like maybe psych and pathology, but not a lot of people switching out. Mostly people from general surgery, orthopedics, neurosurgery, general surgery switching into radiology. So which speaks about the work-life balance that people have. Typically, score requirement, it's not all about scores, very important. Radiology, like many other advanced specialties, is not just about scores. There will be a score cutoff. This is just to make sure that you are somebody who is, who has the potential to pass the specialty boards. That's pretty much it. Like whether you get 240 or 270, doesn't really matter. It's there's just a score requirement that you just need to pass the filter, and then you're in that. What I've seen is the difference from my home country. I'm from India. So what I've seen is a difference in radiology from the US and India is, I think most radiologists in my home country do ultrasounds themselves. They scan and they report themselves. Here we have sonographers who scan the patients. We do have the opportunities to learn scanning too, which we do. But on a regular basis, it's the sonographers that actually scan patients, but we read the studies. I think dictation softwares are better here. PACS and EMR, where you see the images and your EMR systems are significantly better. And I feel breast imaging in general is extremely much more advanced here than any other country. A favorite thing about radiology is the opportunity to work from home or anywhere in the world, and the technology part of it. I do feel like the least favorite thing about radiology is feeling underappreciated, especially if you're a diagnostic radiologist. You're behind the scenes. I know there's so many memes running out there where the radiologists and pathologists are behind the scenes, and people don't appreciate how much they are involved in getting you that complex diagnosis. But every specialty has its least favorite things, and this is just what I feel about radiology. So for everybody out there considering radiology, remember a competitive applicant for radiology is not just somebody with a high score. Think about how you can show your interest in clinical and research aspects of radiology, and whether it's by doing more clinical rotations or by doing more research. And through these rotations and through these experiences, you'll be able to make contacts or connect with different people. And by connecting with different people in a smaller specialty like radiology is what will take you up. Okay, and that's just how it works. Because the more people know you, the more likely that they're able to vouch for you in another situation. So yes, and that's pretty much all I have about for my presentation. I have 3 minutes to go in my time, so I can answer a couple of questions.
So before you answer the question, so like I said, there are some quiz questions. If you answer them, you'll get discounts, coupons, and all that. So Dr. Koshi mentioned about the 5 tracks in radiology. Anyone who can type all 5, the first person to type all 5 will get a discount from Saarthi. So if you were listening and if you will type the 5 tracks he mentioned, then Swati will grab your email. So 5 tracks, all 5, okay? Now, one question I did see was, does radiology harm the physician also in the long run, given the radiations and all that?
Good question. I think many people are worried about that. But when you're in diagnostic radiology, like you're in a diagnostic radiology rotation, you almost never encounter actual radiation. And the only times that you actually may have to be near radiation is if you're doing a procedure or if you're in interventional radiology. And for all of those things, like typically you have lead, you have your radiation badges, radiation safety badges, which I don't know if you know is monitored throughout the country. So whether you go to a different institution, it's still monitored. So your lifetime dose is calculated, and typically nobody ever goes above those doses. So yeah, I think our specialty is doing a really good job in reducing those radiation doses. But if you're in a diagnostic specialty and will never go into interventional, you're almost getting 0 radiation, 11 months of the year.
Thank you. Another pop quiz. What was the exact salary number he showed on the screen? The exact number. If you can type the answer, Swati will grab your email. All right, Swati, grab the first one who said 483K. All right, other questions for him before we move on?
So I see some questions about internal medicine. Those questions will be answered later on.
Right.
I am, yes. Practically, how will the radiologist journey of a home country pathologist? It's the same thing. If you're whatever specialty you are in and deciding to do radiology, it's the same thing. You need to express your interest in that specialty and work to show your interest in that specialty. Yes, getting that score is good, but getting those rotations, getting those letters, making those connections throughout those experiences is more important, whether you're coming in from pathology or not.
All right. Thank you very much, George. Much appreciate your time on a weekend. Very, very helpful.
No problem. Thank you so much. I hope everybody learns a lot about their specialty and other specialties. It's very important that you learn these things because one, not only helps you have intelligent conversations during your rotations, but also during your interviews, whether you're applying this here or not. So all the best.
Thank you. And if you can release the slide share. Thank you. I do have a panelist who has to leave, so I'll just move the agenda around if you don't mind. Roshni Pradeep has to leave in about 10 minutes. So Roshni, she is PG2 internal medicine in my home state of Arizona, so she gets the preference. Roshni, are you there? I know you are on floor somewhere. Roshni? Okay, maybe not. All right, then we'll get back to the agenda. The second one was Zinran. So anesthesia. The floor is all yours.
Hi, thanks for having me here. I don't have a presentation. I don't have a slides, but I do have those questions. And should I just share the question list?
You can, yeah, it's free flowing. You can talk. You can, do whatever you want to do. So you can take a question, answer it, or do it like George did, or free flowing. You just day in the life. What do you do?
Okay. Can you see my question list?
Yes.
Okay. So I will try my best to answer every questions, but I will. I'm only a PGY1, so I haven't do a lot of anesthesia, so I can't speak too much about salary and like a typical day. I'm currently prelims, like surgery prelim, but I can talk more about application aspect.
Sure.
So first, what factors did you consider when choosing your medical specialty? I think I should mention I did an OBGYN residency in China, like in my home country, and I switched to anesthesia. That speaks a lot. So I consider work-life balance, and I consider what I like to do in my during the day and when I'm working, and also what I like to do when I'm out of work. I choose anesthesia because first, the work hour is less than a surgical specialty, and also when I'm off work, I'm off. I like usually I don't get call back. I don't need to like think about my patients during the day. Of course, I prepare for the next patient for the next day, but I just I have like a free time after work. And also, I like to do some procedures. So anesthesia give me some small procedures, and also use my medical knowledge, like pathology, physiology, those all kind of things that I like to do. So if you are choosing your specialty, I highly recommend you to consider what you are good at, what you like to do in the hospital and out of hospital. Do you like to spend all your time in hospital? People say that if OR is a favorite place in the world, then you should choose surgery. But if OR is your favorite place in the hospital, then you can go to anesthesia. And the second question, can you describe a typical day in your life within your medical specialty? So I can speak a little bit about as an anesthesia resident. So in the morning, we report to the hospital around 6 a.m. and we prepare for the room for about like half hours. And then we have like about 1 hour didactics. And around 7:30, we start, the case started. And after we did the induction, we have typically have 10 to 15 minutes morning break. And then we come back to the room, and then we have 30 minutes break for lunch. And in the afternoon, another 15 minutes break. And then usually we got released around 4 to 5 p.m. But of course, you need to read for next day's patients, read their chart and prepare and make up a plan. And that's a typical day for an anesthesia resident. I I assume the attending should be work is like, have less work, like better hours. And third question, how would you characterize the work-life balance in your specific medical field? I would say anesthesia has great work-life balance. I don't know if you have heard the ROAD specialties, ROAD, like anesthesia is we have a good work-life balance. Approximately how many money did you spend on your journey through the USMLE exams? So I didn't spend much on exams because there are like, I bought first aid, I bought a U-Ward, and I registered for the exams. So that's all the money I spent. I spend more time studying. I think time is more precious than the money. And if you face the low scores or red flags, how did you overcome them during your medical education? So I think I have red flags, like so I'm an old IMG. I graduated in 2012. So it's the YLG is almost like 10 years. I think, so for me, I work hard to get a good score and also try my best to do more rotations and do volunteer works. Those are things that I can do to fill up my CVs. And I would say volunteers and rotations are very important, and also network. What is the highest salary one can expect during internal medicine? This is for internal medicine, but I can say a little bit about the anesthesia. So I have heard I have some spot data, like fresh graduate, like residency graduates got like offers around 400K to like 500K, or some can be like 600K. But that's because in recent years we have better job market, and that makes this specialty, I would say, it's quite competitive. So question 8, what are your plans after completing your residency? I think one good thing about anesthesia is our fellowship is only 1 year. So I'm considering a pediatric anesthesia fellowship, but this fellowship is not to like raise my salary or like give me a better job security. It's just because I like to do some cases like for young baby that is required. So I have to have the fellowship to do those cases. And I think in anesthesia, we got good pays even without fellowship. So there is a trend that in most years, people like go to, practice right after residency. I would say less people go to fellowship. 10, what types of rotations do you believe were most beneficial? I think that's those hands-on rotations with anesthesia. And also anesthesia also manage a surgical ICU. So if you can get hands-on rotations in a surgical ICU or trauma ICU, those are very beneficial. How involved are you in research? I didn't do any research in anesthesia. And I don't think it's crucial, but if you have it, it can be very helpful. Like you have to have something to impress your PDs. If you have high score, or you have a very good letter of recommendation, or you have good research, I think research can help you get into a residency program. Just I didn't get it. I didn't do research. Doesn't mean that it's not important. How involved of 12? Did you apply to multiple specialties? I didn't. I think anesthesia is a specialty that values commitment. And all the rotations I did was with anesthesia, because that's also because I'm switching my specialty. I want to demonstrate my commitment. I don't want to give them any impression that I'm applying to anesthesia as a backup. So that's my strategy. 13, what typically happens in the period between the match and the start of residency? So I don't need a visa. I have a green card. So I know some people need to work very hard to get a J visa, like from their home country. They need to get some letters there. So I didn't need that. So I just took a vacation with his families, and also tour, because I moved from the Bay Area to Boston, so I take time to choose a place where I live. Just in what ways is work life in the US different from your home country, and how is it similar? I think so I will start with similars. When you work as a hospital, you really put all your energy, your effort to take care of your patient. That's the same, I believe, across the world. But the work-life balance is better in the US. And even with even as a surgical resident, I think I have good chill days, and when I come home, I can relax. I think people in US, they respect your personal time more. Like when you're off work, they try their best not to call you, not to, call you for some hospital things. That's what I like. 15, how welcoming have other residents and attending physicians been towards you? I would say they are very, very nice to me. English is my second language. Starting at the beginning of my residency, I had some struggles with language, and I never feel like they, they treat me differently. I feel they are very supportive. And 16, what do you consider your favorite and least favorite aspects of your residency? I have many favorite things about anesthesia residency. So I like the work-life balance. I like we don't need to do much notes. We don't need to work too much on documents. And I like we have procedures. I like that when we relieve patients' pain, I like the feeling of accomplishment and the recognition from our patient. And the list of favorites, if I have to choose one, I would say in some occasions we have to, we provide anesthesia for orthopedic patients and some IR patients. So we have to I feel we have some exposure to radiation, but of course we have protective measures. But as a previous OBGYN doctor, I have some scare of radiation. That's maybe not supported by science. So I just don't like radiation. But I think it's more personal thing. Yeah, that should be it. And I can take any questions.
Well, before you take questions, here's a quiz for all of you who were listening and not sleeping or whatever, if you want to get prizes. Where was she living before she started her residency? Which state? She mentioned it. I need the state, US state she was living in. The first person to give the state will get the Swati. Take the emails for anyone who said California first.
That's a tricky question.
Well, I was going to ask them, what was your home country residency, which you mentioned in the first sentence, but then you repeated it at the end. So I thought, oh my God, that question is gone. So I had to come up with a new question. So,
I don't even remember I mentioned I live in Bay Area.
Yeah, I'm listening to all the presentations. But thank you. Let's see if there are any questions. Anyone, any questions for Zinun? Put it in the chat, please, if you have a question, and we will get to other specialty questions. So at this point, focus on anesthesia, please. Yes, we will get to other specialties. So thank you for your patience. What made you choose anesthesia from OBGYN? Why anesthesia? Why the switch?
So a little bit about my story. When I was preparing for this exams, I was planning to do OBGYN because I feel that gives me the best chance to match into a residency because of the experience. And I do like the the procedure. I like to do procedures, and I like this specialty. But I had my son like during this journey, and I think that changed my my expect for my work and for my life. I realized I want some time to with my to be with my family, not only as when I become a attending, even within the residency. I don't it's like 3 to 4 years. I don't want to miss that significant time with my family. I think that that's the biggest thing that made me want to switch. And then why anesthesia? Because during my residency, I worked with anesthesia closely, and people say you have angry surgeons in the OR and happy anesthesiologists. That's very true. Like there are many moments that I wished I chose anesthesia during my previous residency. I know they have because I see their work. I see they put epidural on our patients, and our patients were swimming before they got epidural, and then they were very happy, and they say anesthesiologists is their favorite person in the world. So I know this is a very, very rewarding job, and I like that I can still do procedure. I can work in the OR. That's OR is my favorite place in the hospital. So I think the answer was very clear to me, so I choose anesthesia.
Thank you. Last question. How many rotations do you recommend? Like a number? How many did you do?
At least 3, I would say.
3?
Yeah, but if you have some experience in anesthesia in your home country, then maybe you don't need 3. But if you don't have any like previous anesthesia experience, I would say 3, because you need at least 3 letter of recommendation.
Thank you. Well, thank you very much, Zindan. I appreciate your time. This was very, very helpful.
Thank you.
Moving on, I do have Roshni who's back, who needs to leave. So Bharti and team, if you can just wait 10 minutes. So Roshni, internal medicine, the floor is all yours.
Hi, Pawan sir, it says video is disabled from your end. Is that?
No, you should. Give me 1 minute. Okay, now you should be able to do the video.
Yeah, I'm able to join. Yeah. Hi, everyone. I'm Roshni. I'm a second-year resident in Verde Valley Medical Center. Here it's in Northern Arizona Healthcare. I'm an internal medicine resident. So I'm happy to meet with you all and answer any questions or if you have for me.
So Roshni, why don't you talk about day in the life? You know, you are PG2. What do you do on a daily basis, first year, second year?
Yep. So as a first year, as an intern, we have rotations. Like every year we have to work in the floors, ICU, nights. These are mandatory rotations we have. And as a first year, as intern, we always have a senior, third year resident who's supervising, because we are new to the EMR system, getting used to it, putting orders, working with case managers on discharge. And that is pretty much what the first year is like. We usually, our patient list starts like 7 around there, and then we eventually start seeing more. And we have a CGME cap at 14 at the second year, so it kind of goes increasing every year. So on a day-to-day basis, the life starts like reviewing charts early in the morning, and reviewing all patient charts, putting in orders, anything emergency in terms of drop in hemoglobin, low potassium, identifying, fixing it. Then going for rounds, doing our own rounds once, and making sure what acute things we have on patient, following up on consults, and all these things we do in the morning. And then after that, we have a formal rounds. So as a second year, we are more independent, like our program being a smaller program of 5 residents. Second year, we practice independently, like in ICU, we are alone. In the nights, we are alone with attending, obviously. But we do run most of the hospital with our attending and us. So we get a lot of procedures in the nights and in the ICU and things like that. When we are in the floors, I have an intern most of the time because the list is longer. So one team has one intern, one resident, one senior resident, one attending, and we have 4 such teams in floors. So, and that's pretty much what we do in summary. Is there any specific questions?
Well, I'm going through the list of questions, and I know
Yes.
Kritika is also there who will come in later on in IM. So, what career options are you considering after residency?
So I'm planning to apply for HEMONC. I'm doing a couple of things about it. Quality improvement project research. I presented an ASCO GI. I'm applying for ASCO this year. We submitted in the Journal of Blood 2 research articles. So we're kind of working on that. Next year will be my year for applying for HEMONC. So got 1 away rotation in MD Anderson, which I'll be doing in May. So all these things are my steps towards that, pretty much my goals.
Do you have any work-life balance at all as a resident, or is it all work?
Depends on where we are. If we're in ICU, nights or teams, it is mostly all work. I mean, evening, even if we go, we are pretty tired to do anything else. But on my electives, I do have some work-life balance. Here in Arizona, we have a lot of hiking. We do it even on weekends as a resident groups. We do it. I joined some horse riding lessons and stuff like that, which I do for a work-life balance kind of thing. But otherwise, I'm alone in Arizona. I don't have my family here. I'm an IMG. So pretty much that's my life here. Yeah.
Well, I know you got to rush. You are on floor. So thank you very much. I appreciate your time.
Yep.
Thanks.
I can answer 1 or 2 questions if they have anything, Dr.
Okay. Then how should I overcome low scores if I am applying to internal medicine?
So if it is in the step 1 is pass or fail now. So if you have low scores, the next step to do will be working on things like research. So improving the profile, getting more publications in as possible. And other thing I did was get more rotations. If you're not able to do it in person, like that time there was tele rotations during COVID, got as much rotations. So 4, 5 rotations or more, because an average, you should try to perform better than an average IMG if you have red flags. And I believe research, rotations, and good letter of rec make a big difference. Program outreach makes a big difference. All these, I think, are the major steps which I took.
Well, Thank you very much, Roshni. We'll not hold you back any longer. So
thank you, Bhavan sir. Happy to help. Thank you, everyone.
Yep. All right, next up is our family medicine discussion. So we have Bharti Nikare, Fenil Gandhi, and Nimra Shafiq. So maybe you guys can start. So Bharti, do you want to kick us off?
Right. Hi, everyone. Welcome. Welcome to Sarthi, of course. I've been with Sarthi for last 4 residency. Before residency, I was in for 2 years. So I've been with Sarthi for almost 5 years. Currently, I'm PGY3 in a New York community hospital. I've mentioned that at St. John's Episcopal Hospital. Family medicine, first thing I wanted to just break up this myth that, people who have low scores, attempts, can go to family medicine. No, that is not true. People who family medicine as a backup I'm applying to, no, that should not be the case. So family medicine itself is, if you work with, now I'm with my program for past 3 years, I'm talking to program directors, APDs, they've been telling us that they are looking for the commitment you have here. You can just, do 3 rotations, come from outside, you have low scores, and family medicine is just specialty to have a backup. So don't do that. I would say to choose family medicine, you should have more dedication, willingness to give back to the society. You should show your work through your rotations or whatever work you're doing right now. So I would say
I see that one of the question here is, again, the low scores, red flags. So about the red flags, people say that, the old year of graduation is a big red flag. I am graduate from 2007, came from India, was here came to United States in 2014, and since then, no clinical rotations from till 18. And literally I did like 2 years of clinical rotations before applying. I applied 3 times to get to my spot, the pre-match spot. So, before saying red flag, it is a red flag, you should address the red flag during your interviews or in your personal statement, everything, but do not consider that as a red flag by yourself, to be honest. Yes, people think that, okay, that's a big red flag and you should not, I mean, this is not allowed or whatever. I would say that your red flag should be you own it and you move towards, clearing that. How do you clear that? If you're old grad like me, you do more hands-on, show that you've been working, you know the system here, what kind of, health system or, what happens in the residency, you work with the residents in outpatient clinic. That is what family medicine is all about. So do those more to show that even though your graduation year is long back, you have enough experience here, which can make you ready to, start. Also, if you have some experiences, like now I had experience, I was an MD anatomy back in India. I did residency back in there as well from 2009 to 12. And then started working as an attending there. And then I left everything and came here. Of course, the life took me here. But I'm saying is that teaching experience, I cashed on it a lot during my interviews, because that teaching experience, I did teaching here in, Penn State University as well. So these teaching moments gave me more confidence and to help people, make the simple medical jargon to convert into the simple language, so all these things you need to, whatever you're bringing from your own resume, you should show the program directors, APDs, that will help more to clear your red flags. So don't call it as a red flag, own it and get over it, About the day in life, I would say day in life changes depending upon where you are. Now, family medicine is where you are means PGY 1, 2, or 3. Family medicine is a broad specialty from cradle to grave. You have everyone from literally neonate to the person who is, very, very old geriatric population, and people die in your hands as well. So you have a pretty broad specialty, right? So that's why family medicine has different kinds of rotations. And depending upon which year you are and what rotation you are, the day of life changes. Even though we are supposed to be more outpatient, we should face inpatient rotations as well. The reason is we have some of the attendings which are running their own private clinic, and they are, when the patients get admitted to my hospital, they will come and they will look over and they will take care as an inpatient doctor. So it's like you need to know what happens in inpatient as well. So when it is inpatient, the day is crazy. Like you start early. As an intern, you have to do a lot of floor work. As a PGY2, you are moderating PGY1s. At the same time, you're making many decisions. And as a PGY3, you are overlooking all your 30, 40, 50, 60 patients at once. So the day of life changes depending upon your level. At the same time, if it is outpatient clinic versus if it is palliative care rotation versus any elective, it's different. So if I go outside, now I have chosen my own path that I have, I would be as an outpatient attending later. So that is my life. So I'm looking forward to the life which starts, the day starts early and finishes early, like 8-hour job. So I think that will bring work-life balance, but don't think that residency, you are looking for work-life balance. To be honest, you are here to learn. So don't take residency as, I want a pretty good life as a resident. No, give your best, use all your time even if it is, even if you are an easy rotation, you have a good amount of time, use that time to learn more, read more. So this is now the time to make mistakes. You have someone else to cover you, that some attendings licenses are on stake, but you are safe at this time. Making many mistakes now is better than making it as you go out. So don't worry about work-life balance as a resident. I would say just take that thought out. Think about, work-life balance after you become an attending. So because it is more broader, you have different options outside. I would say outpatient attending as a 9-to-5 job versus you can do as an inpatient hospitalist as well. We have different specialty fellowship as well, like palliative care. We have a lot of residents gone to palliative care, sports medicine, even I think addiction medicine as well. So we can go different aspects. I think one of us team also applied for OBGYN, that is the women's health. So we have different options of fellowship if you want to pursue more and be more specific. But I chose to stay not doing fellowship because one, I am old grad. I want to start earning early finally. And two, I want to be more broad. I like the part of the specialty to be advocating for the patients, to be the first one to talk with the patient, to take care of them as, you kind of make them as your own family and they believe you as they're part of the family too. So that part of the specialty I love the most, and that's why I chose family medicine. And I think we have more people who can talk more about their experiences and go ahead with remaining questions, or differently that experiences are different, so same question can be answered too.
Thank you very much, Bharti. So just note to our attendees, please put questions in the chat. So you're putting it in Q&A as well as chat. So we are looking at the chat here. And here's another pop quiz, and the first one to answer will get a discount. When did Bharti come to US? She had mentioned it in this talk. So give me the year. Okay. Anyone who said 2014, Swati, you can grab their email. Good. All right. Let's move on. Fennel, your perspective on family medicine. Why don't you introduce yourself and then, talk about it?
Sure. Thank you, Bharti. That was a very, overwhelming and very informative introduction about family medicine. So I'm Fennel Gandhi, PGY1 Family Medicine at Lower Bucks Hospital here in Pennsylvania. I'm also went to medical school in India. I came here in 2019. After that, COVID hit, and then I was backed up. So I decided to do master's in health administration, which really taught me about the specialty that I wanted to choose. Coming from India, I was looking at internal medicine, but after doing master's in health administration, I saw the different perspective. I met FM residents, EM residents, OBGYN during that course, and that's when I decided to do family medicine. When I was doing my MHA, I was also, doing my USMLE exams. When doing my USMLE exams, I definitely had the opportunity to apply for IM and FM both. I decided to apply for FM only because that was the specialty, and that's what I saw myself as working in the future. Just like as Bharti said, don't treat FM as a backup specialty. Don't treat FM as like anyone can get into. It's really tough, and more American graduates are pursuing FM because of that work-life balance that everyone keeps speaking about. The main difference between FM and IM, I would say, is the fellowship options, right? Internal medicine, you have more fellowship options compared to FM. FM, you do have fellowship options, but they're outpatient-based, mostly, not inpatient like rheumatology, GI, cardio, etc. So that's a little bit about myself and why I chose FM. I'm getting a little questions in the chat. I know Bharti answered a lot of questions. I'll go over those questions in a bit. I want to answer in the chat because I was in that position once and asking those questions. So I think I answered the family medicine, internal medicine one. And same thing again for what made me change from IM to FM. When I was doing my master's in health administration, I saw the administrative aspect and the medicine aspect both in the same time. So that's the reason why I chose FM. Okay. Yes, FM can be an internist. A lot of my attendings, they work as an internist and as an outpatient. They have joined groups where they work with other internal medicine doctors, and they see the patient as a group, not as an individual. Okay. So hospitalist fellowship you can definitely do, but you can work as an internist after graduating from FM residency. What my program director has told me, and what he likes to tell everyone, which I really appreciate, is you have to figure out what you want to do in the beginning of your residency and then aim towards that goal. If you want sports medicine, get more sports medicine electives, get more sports medicine rotation, so that way you can get to know the field. And when you're doing that rotation, it can change your mind, just like how I changed my mind. That you don't want to do sports medicine anymore. So you can check that off. If sports medicine is what interests you, then you can make contacts, you can develop connections, and you can pursue that fellowship after your FM residency. So it can help both ways. Secondly, okay, so I think that was it. I cannot comment on OBGYN fellowship because I don't know much about it. But as FM, you are responsible of delivering babies. You are responsible of being present in the OR. When there's a C-section happening, you are responsible to take care of the baby, after the delivery. So you work closely with OBGYN, you work closely with pediatrics. My program, we have 1 month rotation in OBGYN oriented hospital where we take care of mothers in that during 1 month who are in their later part of their delivery. We follow them throughout their delivery. We follow them after the delivery. We follow their kids up until they are about 1 year of age. So that's a good experience that my program gives me. And again, I'm sorry, but I cannot comment on OBGYN fellowship at this time. Okay. How many rotations do you recommend? Same thing as what the anesthesia person answered. I would definitely recommend about 3 to 4 rotations because you need those letter of recommendations. So I'm also on the interview committee for upcoming residency match. And when I was interviewing candidates, I was looking at how many FM rotations do they have? What do the FM doctors have to say about them? I did come across a lot of applicants who were dual specialty applicants, but I did choose them because I saw their passion towards FM, and then your letter of recommendations, your personal statement will show that. That's the one way that's the one way I differentiated if this person is keeping FM as backup or does he genuinely want FM residency. So I would say 2 to 3 or 3 to 4. Salary difference between IM and FM. If you're working as an internist, there's not that much of a difference. You can Google this question as well. If you look at New York salaries, they start from anywhere from $250K to $300K. Same thing as internist. Obviously, internist, if they have a fellowship, then they're earning more, but they also have to put in that more time and effort into that. My plans ahead, I am not looking at anything currently. Possible sleep medicine in my second year. First year, I just wanted to go through all my rotations and then see what I like, what I don't like, and then make my decision after. And what are the scores cut off for most programs? So you can use tools like Frida. US Family Sarthi has its own tool. Then just every program is different. There is no cutoff on scores depending on specialties. There are cutoff on scores depending on programs. If you're applying to a community program, they're more willing to accept lower scores and looking at candidate as a whole. If you're applying to university programs, they worry more about your scores and they want a higher score candidate. So that's the major difference that I could say. What's the difference work-life balance between IM and FM? Work-life balance between IM and FM, there is none. It depends on you as a person. I know attendings who run their clinics from 8 a.m. to 6 p.m. They're working that shift. They're putting in their hours. I know some attendings that work from 9 to 12, that work from 1 to 3. They work 4 days a week, 3 days a week. So it depends on your personal goals, your personal careers, and how you want to do your work-life balance. When speaking about IM shifts are usually 12 hours. They work from 6 to 6 or 7 to 7, 7 days on, 7 days off, or 2 weeks on, 2 weeks off. So that's how the work-life balance is between them.
Fenil, I'm getting other questions for older graduate, 5-year graduation red flag. And that's where I think Nimra can come in. She's also FM. So she was an old graduate. And
of course,
maybe she can answer this. I don't know if you have experience, but Nimra, are you there?
Hello everyone, how are you? I'm here. Same as Roshni. I cannot, I don't know why I cannot do the video.
Okay, let me see now. Okay, can you try now? Okay. You should have, otherwise, the audio should work. Let me make you the host. So give back the host permission after you're done. So You should be able to do it now. Does it work? No?
No, it's not. I don't know why.
Okay, well, let's try audio only. So why don't you share your journey? And since you're an older graduate, there are a lot of questions on visa, old graduate, red flags. So why don't you share your journey in FM and, talk about it?
Yeah, sure.
Can you hear us, Nimra?
Yes, can you hear me now?
Yes.
Okay, so as Pawan told everyone, like I'm old medical graduate. I graduated in 2016 from Pakistan, and then after that I came to Canada in 2016, and then I started to working to do some licensing exam in Canada initially, but later on I decided to switch to US as well. So I started to give exams in US, like USMLEs. So if you say I applied in my first mat in 2022. So I graduated in 2016 and I applied in 2022, and I matched in my first cycle. And Pawan might know, like I received very, very, very few interviews regarding to that. But as Bharti and Fennel told you guys that the family medicine is not like should be a backup plan because like the program directors and everyone, they can know and they can see how committed you are to your program and to your specialty. So I was working in Pakistan, and I was working like volunteer in Canada, as well as I do some rotations in US as well, like tele rotations. But even though if I graduated in 2016, but I was like there was no specific gap between doing stuff. And if I'm saying like there was no gap, I'm including my volunteers, I'm including my working in Pakistan, I'm including my working in US and Canada. So when you're applying to programs also, you can see sometimes I imagine, like I'm PGY2 right now in family medicine, St. Elizabeth Mercy Health Hospital. And when I remember when I was into their website before applying to the programs, they were like, I cut off, like we accept only 5 years graduate, like year of graduation. But I applied in that, and I have like long graduation gap, but I matched there in my first cycle. So it depends, like program directors and everyone, they are so experienced that they can know how committed you are. And if you are confident that you can justify that you are committed and you are not just sitting over there and just like passing the time, but in that time period you are doing like hard to be in the system, like medical system, and be a family medicine resident, it really helps you with that. So regarding some questions like fellowship, Bharti and Fennel also covered that, like sports medicine, OBGYN, palliative. And recently when I was like in my intern year, I had a plan to do a resident fellowship in ER. And I was total like, I really like that. But after that, I got, I had another baby. So I switched it to, now I have a plan to do a fellowship in aesthetic medicine. So it's very vast, family medicine. You can do a lot of fellowships, but depends on your program. If they can you can do that fellowships from your program, or you have to apply somewhere else. But definitely you can do whatever you want, kind of thing. Other than that, how can you overcome your red flags? I have talked already about that, like do your work on that. Research will help you. But I can say being a if you have like committed to family medicine, more clinical or hands-on experience will be more appreciated than the research, I can say, because family medicine is more towards like how you treat your patients. And I know, and step 3 is also really important. I know when I talked first with Dr. Pawan, and he was like, you have to give step 3, and I gave step 3 like, because like in 20 days before applying to BAT. So Sarthi really helped me to apply to programs and how to overlook my red flags, how to overcome those things. And what else? other question I was having, like how welcoming have your residents attending physicians towards you? So when I was applying to that program, I remember usually we go to the program website and we are seeing usually like what residents they have, if they have like AMGs or IMGs. I remember all the residents were AMGs. So I was like, should I apply in that program or not? But I applied anyway and I matched there. So I was like first IMG in that program. So I can say like it matters obviously if they have previous resident IMGs in their program, but if you are like, you can say, okay, I have like, it depends on your luck as well as like your commitment to the program, just apply there. And after, if you get lucky to get interview, outreach is so important. I cannot emphasize enough on outreach in the programs. Again, thanks to Sarthi, they helped me a lot in how to outreach programs in a good professional manner, not like just like throwing emails on them, like how to do outreach to them and show them their commitment towards their program. And being an IMG, I was the first IMG in their program and they chose me. And when I was later on, when I talked to my program director, and they literally told me like, the outreaching had really helped me. And they were, I was worried about my year of graduation, but when I talked to them after some time, so they were considering as like I am, because I told you like I was doing some work in Pakistan, Canada, volunteers even. So they were like, even though I graduated late, but I have experience. So they were like, okay, you have like, you are a little bit more, superior to the new interns because you know it already. You have done that work. So that's what I'm saying, that it doesn't matter wherever you work, everything counts. The main important thing is like your commitment to the program, to that specialty. So other question.
Let's see if there are any others. Nimra, meanwhile, can you make me the host back on the top of your screen? There should be 3 dots because you have the host permission. So you have to make me the host back. So that I can allow others. So don't leave without making the host. Do you see that?
Yes.
Okay, make me the host and
Yes.
okay, thank you. So yeah, we'll take other questions if I see them. Okay, meanwhile, we can move on. So the next is pathology. And I think we have Arshi Sana here. So Arshi, all yours.
Hi, Pawan. Thank you for the opportunity. Welcome to Sarthi webinar, everybody. So my name is Asma Arshia, but I go by Arshi, and I'm a PGY3 resident at the University of Kentucky, and I will be an incoming fellow at the University of Michigan in 2025 in cytopathology. So I want to do this just like any other panelist. I'll go through the questions and then answer them to my best knowledge. So the first thing that I would like to say, the first question is like, what factors to consider when you're choosing pathology? So I'd like to say to anybody who has this misconception that, you can interact with the patients or anything like that, or somebody who's very passionate about the patient interaction, this field is not for you for sure, because you have a very limited patient interaction and there is no direct patient care. Just like earlier, the radiology panelist mentioned, how they will interact with the patients, but for us in pathology, it's more like very limited, especially in apheresis, and then cytopathology, you go on procedures and all that, but there will be very limited interaction with the patient. But if you are like Dr. House, if you want to play Dr. House and just not interact with the patients and just do the diagnostic challenging aspect of it, then this field is for you for sure. And then the next question that I would like to answer is a typical day in the life of a resident, especially for us, depends upon the rotation. We have different rotations, which are like, some demand a lot more work than compared to the others. For example, like in Search Path, because if you're doing an AP-CP residency, AP rotations require you to put in a lot more hours than the CP rotations. So in anatomic pathology, of course, a Search Path is the most heaviest of all. Like my work day in a typical search path rotation goes like, we have 1-day cycles, which means we have to preview the cases, we have to sign out with the attending and also gross everything on the same day. And some programs have it like a 3-day cycle where they distribute the work in amongst 3 days and then the cycle repeats again. So for us in our program, we have 1-day cycles where in the morning you sign out with the attendings with all the cases that you have previewed the previous night. So actually my work day begins at 7:45 in the morning, which we'll have 1 hour of didactics, and then you sign out with the attending. And then we, in the afternoon, there is not specifically a lunch break or anything, but it just depends upon how you organize your day. You can take a little bit of break and then have lunch and then go up for grossing the specimens, and then it goes until like 5 p.m. or 6 p.m. depending upon how much you have on your bench. And then and after that, you can just take a little bit of break and then go back to your previewing the cases. And sometimes the day ends at 9 or 9:30 in the night. So they can be really long days and long hours. But if you are on a CP rotation, for example, like a blood bank rotation or on a micro rotation, so your day, again, it starts with the didactics, but then the day will not be as long. It just goes until 5 o'clock or 4 o'clock, depending upon what you have to do that day, like if you have any assignments and things like that. But those are the days that I would definitely take advantage of and read more upon and learn. And it depends upon how much work you put in is what you get out of it, right? So as other panelists have mentioned, how much ever, if you work hard during the residency, then you will be less likely to make more mistakes after you come out of the residency. And when you're working as an attending, it will be much better on you. So yeah, that's how my day goes. Then the next one is the work-life balance, of course. So it's favorable comparatively to the other fields, definitely, I would say, and also depends upon the private practice versus academic. So if you're in an academic setting, definitely your time will be distributed between like teaching, education, research work, and also the clinical work that you're doing. So it depends upon like if you are going into the private, obviously you're expected to do more work, and there is all these other things that the research, teaching, and spending time with the residents and all will be reduced. Obviously you'll be earning more money for a reason, because you're looking at least 200 to 300 slides a day. So it all depends upon like whether you're going into a private versus academic. And also in our field, we have more of a predictable hours, you choose to work how many hours you want to. And as a resident as well, we have like Saturdays and Sundays off. So that's a good work-life balance, I believe. So we can catch up on anything that you like, your hobbies and things like that, along with your reading and everything on the weekends. So that's good. And we have less number of calls when compared to the other, fields. And it's a more structured schedule for sure. So that's about the work-life balance. And then the next question is, salaries ranges after the residency. So it depends upon suppose you're on a visa and you have to get a waiver job. I think the most of the waiver jobs, they start from like 180 to 200K on an average in a remote US state, somewhere like if it's a malignant. That's what right now the salaries are. But again, if you can get a good waiver job, the salaries can be from like 200 to 250K, and in an extremely rare cases up to 300K as well. So and also if you are going into the private setting, then you cannot get a partnership until you get a green card if you're on a visa. Even in that case, if you will be starting your salary from 200 to 250K in the beginning, for the first 3 years, even in a private setting, where you will be obviously you'll prove, that you are capable of that partnership or whatever. They will not give you partnership right away, but the first 3 years you have to prove yourself, and then from there, the partnership will be offered once you get the green card. And obviously, when there is a partnership, you will earn more, like from 400K to up to $1 million as well. There is a potential, but then the problem is you're also risking it, like you're investing your money in the partnership, right? Like obviously, if the practice goes well, then you will be having good returns. But if you do not, then obviously you're losing your money as well. So there is a risk. And also the number of hours that you put in, that is that how much you earn. It's not like you work less and you get more money, right? So that is a very important factor over there. And also depends upon the academic versus private setting. Again, the salaries can change. In academic setting, you have obviously less amount, like 190 to 200K is the beginning when compared to the private, and also geographical location matters. Some places they have like, very high cost of living. And so obviously salaries will vary based on the location. And also it depends upon your negotiation and your skills and things like that when you're interviewing for the jobs and how it aligns with the needs of the institution. It all depends upon those things for the salary and everything. The next question is, obviously options after your residency will be a lot of them, like, choose to do a fellowship. Like anesthesia, we also have like only 1 year of fellowship, so people can choose to do one fellowship versus like 2 fellowships. But nowadays the trends are changing from 2 to 1 because of the good job market. And so people choose the fellowship, or they do the waiver jobs, or go back to the country if they are on visa, of course, and then come back on H1 again. Or if you are from a Middle East or something, like Dubai and Qatar are really good places with the equally competitive salaries, and obviously there is no taxes there. And Canada is another good option to go to, and any other like English-speaking countries like Australia and New Zealand, you have opportunities with the US residency. And also in European countries, you have good opportunities as well. They have comparable salaries too. So those are all the options that you will have after the US residency. And coming to the fellowships as well, like you have a lot more options like heme path, derm path, and cytopathology, so surge path and cardiopath, and all these different fields to choose from. But again, like there are some fellowships that are very competitive when compared to the others, just like in any other field. And you have to, show your passion towards it, and obviously work on some publications and research and things like that. Obviously, networking goes a long way, letters of recommendations for sure. So yeah, and I'm also on the committee for choosing the upcoming, residents in our program. So I see that a lot of people who have done observerships or rotations with us, we tend to kind of see them in person and then kind of get an idea about how that person will fit in the group of residents. So the teamwork and all these things matter a lot. Teamwork skills and how willing are you to help? That's very important, because in pathology as well, some days can be really very tedious, and sometimes people have to cover for each other, and they obviously look for the teamwork. That's very important. So those things are very like being, first of all, having a good academic record and being good with all your attendings, having good letters of recommendations, research and publications, networking, going to the conferences. So all these things will make you more competitive in your application for pathology, for sure. And the next question is, how involved are you in the research as a part of your current residency? I would definitely say that, like I mentioned earlier, we have some lighter rotations or lighter like CP rotations and all, where you will have more opportunities to do more QA projects or work with your attendings one-on-one to come up with a project or poster presentations, or, to the ASCAP meetings and things like that. So I do get opportunities from time to time to work on my publications and research. And I make use of those lighter rotations, especially the CP rotations, because AP is really heavy with the workload and everything. So I usually don't find time during those rotations. And then, yeah, so in what, so the next question is like, how welcoming have the other residents and attending physicians have been towards you? Yes, I feel like in our program, we have a more collegial environment and very like diverse people. My program has a lot of people from like India, Pakistan, Egypt, and like many other places like Caribbean, Africa and all. So it's like a diverse cultural environment, and it's very supportive and very nice, especially amongst all the other fields. I feel like pathologists are the most nicest people I have met. They are very, very friendly and easygoing, and we all have like a kind of rapport. And I really enjoy being in this field for sure. And my favorite aspects of being in this field are definitely the intellectual aspect of it, the diagnostic challenging of the solving a case, and then the second is like collaborating with the different clinicians and radiologists. Especially when you're going for the cyto procedures like FNAs and all, you will have direct interactions with the radiologists where you're working on the procedure. And the variety of fellowships opportunities that you have, and the opportunity to work on the research, teaching and education and things like that. Those are all my favorite parts. And the least favorite, if I have to pick, so that would be like, obviously just like radiology, it's underappreciated. So that's what I feel like it's common. So yeah, I mean, if you have any other questions, please feel free to ask. That's all I have.
All right, before you ask questions, here's a pop quiz. You will get discounts. She told her real name or the full name just when she started. So anyone who remembers or was listening, if you type it out and the first one to type will get a discount. So, I'll take a look if someone types a real name.
That is a tough one, Pawan.
Someone did. Okay, Asma, yes. So Swati, grab the email. And all of you, people are asking what does the schedule look like. So as you know, our panelists are going in and out. So we have slight changes. After this, we are going to talk about general surgery, then IM, then a couple of FM panelists, new panelists are here. We may get to psychiatry after that if I see the panelists. Otherwise, after IM and FM, neuro and pediatrics. Okay, so just so that you know. So we'll keep moving. We hope to get done in maybe another hour or so. And to my panelists, if you're done, feel free to leave. Thank you very much, Arshi. I appreciate. If there are questions, you can look at the chat, but I will also let you know.
Sounds good. Thank you, everyone. Thank you. All the best.
Thank you. Let's move on. So, Akhila, are you there?
Yes, Pawan, I'm here.
Okay. So you should be now able to share your screen and talk about your journey, your experience, and your specialty.
Sure. Hi, everyone. I'm Akhila Charukuri. I'm an IMG from India, currently doing my PGY1 general surgery rotation as a prelim at SUNY Downstate Medical Center. So first thing, how did I choose my specialty? So during my med school, I was pretty much into general surgery, and I never changed my mind, irrespective of people telling me the difficulties of getting into general surgery, whether it be in India or be in America. And when I chose to be when I chose the residency at United States, despite choosing the residency at United States, I never changed my mind. I was stuck to the specialty, which I love, because at the end of the day, you should love what you do. And if not, you won't be able to, give your 100% and do the best. So that's how I chose my specialty. And I would say the same thing to anybody. Yeah, you can always have some alternatives. I know things might not work for everybody, but I would say try your best, give your 100%, and try to stick on to the specialty that you really love and that you're really interested, irrespective of the difficulties. There is nothing that's impossible. It might be a little difficult, and you might need to put some extra effort and time, but eventually things will work out. So that's my suggestion for anybody who wants to get into general surgery, even in the United States. Because there are many people who really did it despite doing a prelim and then repeating their categorical position. If you really love it and you are passionate about it, go for it. And the next question that I would love to answer is, how is my typical day in residency? So surgery is a little different. We literally start our day around 5:30 and start our rounds by 6. Our day would be from 6 to 6. And most of the programs, especially our program, SUNY Downstate, is very particular about the work hours. Like, they don't want us to get overwork and overwhelm about the work hours. So they make sure that we only work 80 hours a week. But at times, when you scrub into a case and you might have to continue rather than scrub out of the case, you cannot leave the case in between, right? So at times, and whenever there's a trauma or some emergencies, like surgery is known for emergencies, like you have to deal with a lot of emergencies. So at that time, you have to work a little more. You have to put in extra hours and work. So they do let us, start later on the day. And so they make sure, especially our program, make sure that the resident is not burned out. And we work to, everybody works less than 80 hours or to 80 hours. And like I told you, surgery has a lot of emergencies depending upon which rotation we are. If it's gen surge, there are gen surge emergencies. If you're doing a trauma surgery, there are trauma surgery emergencies. So we tend to attend all of them, and depending upon our level, like I'm a PGY1, so I tend to rotate with most of the gen surge, vascular surgery, and trauma surgery. So during these rotations, depending upon the place, like ours as a university program, we tend to rotate at SUNY Downstate, at Kings County Hospital across the street, right opposite our SUNY Downstate in Brooklyn. And we also work at Staten Island, Richmond University Medical Center. We're also affiliated to Coney Island Hospital, which actually started a new residency program this year. And we also work at MSK, which is very well known for its oncology, surgical oncology. So depending upon the sites, as a PGY1, we might have to do some 24-hour calls, and our typical day would be from 6 to 6, but at times it might extend. That is all. And the next question that I would love to answer is about research. Before joining in residency, I was active in research at Mayo Clinic, Rochester. And since I had a gap year, I didn't want to show something new in my application when I applied for the residency. So I wanted to do research because I finished my step 3 as well before I applied. So research is not really important if you are not interested in it, but if you're considering for a fellowship and if you're applying for university programs, I would say research is really important in that case. But if you're applying for a community program, they might not really stress on research. But if you're applying for some fellowships, especially pediatric surgery, like you're considering for it, or cardiothoracic surgery or hepatopancreatic or biliary, these are very competitive fellowships, and surgical oncology as well. You are supposed to dedicate at least 2 hours of research. 2 years, sorry. 2 years of research. So if you have a good research background, even before you start the residency, that would be a plus point for you when you're actually applying for university programs. And my program, SUNY Downstate, is very particular about research. My chair, who is a vascular surgeon, he loves research, and he appreciates, and he would help everybody who's interested in research. So again, especially if you want to do the fellowships, like the competitive fellowships that I just mentioned, I would say you should, look into research and try to gain some research experience even before you get into residency. Let me see.
Akila, it's okay if you cannot see the questions. I think you are on a phone, but we do have Tejasvi also
Okay.
in surgery. So, Tejasvi, are you there?
Hi, Pavan. Yes, I'm here.
So, if you want to take on from here and answer questions or just share your experience, that will be fine too. I know Akila is on the phone, so.
Sure. Can I start now?
Yeah, all yours. Whatever you want to discuss about general surgery, like how many, rotations, how do I get in, what is the work-life balance, what's your favorite part?
Okay, sure. Hi, everyone. I'm Tejasvi. I'm an IMG. I'm doing a second prelim year at Montefiore here in New York. I would want to talk about some of the misconceptions people have about surgical residency in particular. And I agree with most of the points which Akila said. People tend to think that we don't have a work-life balance, which I don't think is true. Like Akila mentioned, even my program is also like very particular about the hours that we work. In my first year, I used to start at 5:30, but I'm in my second year now. So my typical day starts around 6 a.m., depending on which rotation I'm covering. So, and I take calls like twice a month, but that's about it. So, and every time that I take a call, I get like the day off and the week off. Sometimes I have like a golden weekend, which is like Saturday, Sunday off, and even a platinum one, which is a Friday, Saturday, Sunday off. I'm off today, so I'm at home. And yes, we do scrub into cases and which go in emergently, but my program has this concept of like whoever comes in after your work hours are over, they tend to scrub you out, and it's your choice if you want to stay, continue scrubbed in, or you want to like do part of the case and then scrub out, go do your work. So that option is always there. You're not forced to stay beyond your work hours. So we never cross the 80-hour work limit. Most of us even do less. On some rotations, I even did like 30 to 40 hours a week, which were lighter rotations. So when you first start your residency, like in your first year, you're a little bit overwhelmed because you're still figuring out things like how to manage work and family and everything. But I think by the time I was towards the end of my first year, I kind of like figured out how to manage both things. So I think we all like can figure out our own plans. Like I don't do a lot of social media. I don't have time for that. I don't watch a lot of movies, which I used to do before, but I prioritize other things. I try to spend time with family, friends. And one other thing which I learned from few of my chiefs is when you are working nights, make sure you sleep if you can. I sleep when there are no patients. I sleep at 7 o'clock or 8 o'clock when I'm doing nights, and whenever there are patients, I wake up, I take care of them, and I go back to sleep again, because the next day when I have a day off, I'm not sleepy and I can actually do my work. I can spend time with my family and all that, or study. So you will figure out those things on your own. Like you will figure out ways to balance your work and life, and have a life actually. And what I like and what I don't like about my program, or my specialty as such. So I was always passionate about wanting to become a surgeon, and I had a lot of people, including family, friends, who told me that it'll be very difficult, especially as a woman, and given the conception of this work-life balance and surgery being a difficult field. But you have to actually like what you do in any specialty in medicine, I think, because if you don't like, that'll be a burden. You will not be able to balance because it takes a lot. You have to wake up early in the morning. You have to work long hours sometimes. It's physical burden, it's emotional burden, mental burden, everything. So you have to love what you do. So I would suggest that you figure out early on that you actually want to do so and so, whatever it is, surgery, family medicine, pediatrics, whatever. You should be passionate about it. And once you've made up of your mind that you want to do this, you do it no matter whatever people tell you. You will find your ways to like that. And if you like your job, you will not be stressed at work, is what I'm saying. What I don't like is I don't have the luxury to have long showers or sleep for long hours, I would say, which most of us like. But yeah, I hate every morning when I have to wake up at 4:30 or 5:30. But yeah, that's how it is. Like I still hate it even after 2 years. But I think yeah, once I wake up and go to work, I'm fine. After like an hour or so, I'm fine about that. And then I come home by 6 o'clock every day, except when I'm working nights or some days, which are like, suppose I'm working on trauma, or if I'm working on general surgery here at Moses. Those are some busy rotations where I sometimes tend to stay back like around 7 or 8 p.m., but those are not everyday things. So yeah, I think I would want more people to come to surgery and not have this misconception that, oh, we'll not have a work-life balance. So
Well, yeah, thank you very much, Tejasvi. I think it answers a lot of questions that we are seeing on the chat. But thank you for your time. If there are other questions, I will get back to you. Thank you. So moving on, I know some of our panelists have to leave, but let's do IM, and then I think Pradeep, you are about to leave. So we'll do IM and neuro. And then I did see Taufik now joining pathology. So, if it's okay, if you can wait a bit, and Sahil, psych. So we'll cover all of these. So let's start with IM. So Darshi, Preetika, and Vineet, I think you are in IM. So Darshi, I know you've been waiting patiently, and so about Darshi, if anyone has heard of 51 interview invites in internal medicine, if you want to see who that person is, that's her. And that is enough of an introduction. So take it away, Darshi.
Thank you, Pawan. Hi, everyone. My name is Darshi. I'm one of the second-year internal medicine residents here at University of California, Riverside School of Medicine. I was also an international medical graduate. I did my medical school at BJ Medical College in Ahmedabad in India. And I was a fresh graduate when I applied for residency, but like ever since I started my medical school, I was really interested in internal medicine, and that was the only thing I wanted to do. And I was also very clear that I wanted to pursue my career here in the United States. So I was pretty dedicated through my medical school till the very end. And I did get some rotations. Unfortunately, when I was applying, there was the whole COVID pandemic situation. So I wasn't able to get a lot of, rotations here during my my internship, which would count as electives. But I was able to get some observerships, some externships, whatever I could after the pandemic ended and we were allowed to travel. I had about 6 to 7 rotations in internal medicine before I applied. And I also had some like rotations going on during the interview season. So at the end of everything, I had about 9 to 10 months of rotations specifically in internal medicine. And additionally, I did have some research experience as well. I did an observational study when I was in my medical school. And after that, I did some case reports. I also was enrolled in the USMLE Sarthi research course because I wanted to learn more about research and also publish more. I had a chance to publish 2 abstracts, present them at EHA. So I had a good amount of research, like publications and research experience also before I applied. And I had decent scores as well. And I think with all of that and a very dedicated strategy, a well-planned strategy for the whole math season, helped me fetch 51 interviews, out of which I appeared for, I think, 48, 49. I did not give the pre-match ones because I was very, very sure that I wasn't going to take that offer anyways. So I left them alone, but I sat for 49 interviews. So my dedicated match strategy, I mean a well-planned, well-thought strategy, including, your timing for your, like, writing your personal statement, your first draft, second draft, third draft, you're writing your CV well, also sending the letter of interest on time, the letter of intent on time, multiple rounds of letter of interest, not getting tired, just going all in essentially. And also keep doing something while you're also giving your interviews. I kept working on research projects. I kept doing rotations as much as I could until my last interview. So that overall shows your dedication to work hard, to the interviewers, and it kind of shows your dedication towards the whole field and to the fact that you are really interested in pursuing a career in internal medicine or any specialty, as for that matter, here in the United States. I also practiced interviews. I think like your profile can get you an interview, but the interview itself makes a lot of difference. So practice your interviews well. And yeah, I think that was the overall strategy that I used, and was also one of the reasons why I think I got 51 interviews. I do have some other questions here as well. What does a typical day in internal medicine look like? It depends on what rotation you are on. As a part of your internal medicine residency, if the categorical internal medicine residency is for 3 years, you will have most of your rotations inpatient. You will also have your continuity clinic. My program does not offer a primary care track, but a lot of programs do. So if that is what you choose, then you'll do a lot of outpatient medicine. But overall, as a part of categorical internal medicine residency, you will have inpatient versus also outpatient medicine. If you're on like floors, like inpatient hospitalist rotation, then you will have, at least our program has 7 to 7 work hours. So we usually start our day at 6:30, get sign out, chart review round. We have noon conference every day from 12 to 1, where we also have lunch. After that, re-round, finish your notes. And if you're on short call, you get to go home at 5. If you're on long call, you stay back until 7 to take new admits. We do not have more than 12-hour calls in my hospital. We also get 1 day off when we are on like intravenous floors rotations and ICU. We also have nights, 2 months in the first year, and then 1 month after that per year. If you're on lighter rotations like electives, then you work 8 to 5 and that's it. Consult services are also 8 to 5. So your typical work hour and your typical day would kind of depend on what rotation you are on. You do get a lot of chance to work on research. We have a month of research in our second year, where I did get a chance to work on a lot of case reports, original studies, QI projects. So you will get time to work on research as well. And options after internal medicine would actually, there is a lot of things you could do. You could practice as a hospitalist, meaning you can be an internist and do 7 to 7 shifts. Usually that's 7 days on, 7 days off, unless you choose to work more. But usually it's 7 to 7, 7 days on, 7 days off. You could do primary care, which is mostly outpatient medicine, or you could also pursue fellowships. As you all might know, internal medicine offers a lot of fellowships in the future. I am personally interested in cardiovascular medicine, but there's a lot of other fellowships too. So you could either choose to be, you would also choose to do like a fellowship. Okay, what other questions? My favorite part of internal medicine training, I think it's just the breadth of exposure and everything that internal medicine has to offer, including procedures. I love doing procedures. And I think that's also one of the reasons why I chose internal medicine. And I want to do cardiology in the future. So that plus it's like it's a very diverse experience, as you might have seen already. So yeah, that was one of the reasons why I chose internal medicine. One thing I don't like about internal medicine would be obviously people who really are interested in like procedures like surgeries, then you might not be able to pursue that. A lot of fellowships might offer interventional like procedures like interventional cardiology, interventional GI, but if you want to do surgeries, then internal medicine might not be a good pick for you. But my advice overall would be to just go for whatever you like, decide that early on and work on it. Have a very, very dedicated, well-planned strategy for the whole math season. Your math season does not end the day you submit your application. It goes on until the real match date is out. So you keep working hard until March, and I think the results will show. Thank you.
Thank you. Thank you very much, Darshi. As always, very, very inspiring. I appreciate it. And I know you're very busy, so I'll stop it here, and others can answer the question. So don't worry about it.
Thank you.
But thank you for joining.
Thank
Preetika, can we go to you? Continuing internal medicine.
Hello everyone, I am Preetika Sharma. I'm PGY1 with the Wright Center in Pennsylvania, and thank you so much, Pawan sir, to have me here today. And thank you, Darshi. It was a very good, I think, like an overview of the internal medicine residency, and I hope the audience really learned from it. So I'm just going to answer a couple of questions here. I'm going to answer this question, like what happens when you match. So after you match, like you get your result in March. So your program is going to reach out to ECFMG, and they are going to like send a TPL, which is like a training program, like an account to the ECFMG. So that depends. Oh, I'm so sorry. I'm just going to connect my battery just died. So sorry. I'm just going to connect this.
We can hear you.
No. It's just the battery.
Okay.
Yeah. So when you match, your program is going to reach out to ECFMG, and they're going to open an account. So when that happens, your program is going to send you an email that your TPL has been opened with the ECFMG. So my advice is to go and immediately start with the application, because ECFMG has that, like it's a first come first serve. So whenever that opens up, your account is open up with the ECFMG and you don't start the application, then you're going to go behind the line. So when that happens and you get an email from ECFMG as well as from your program, just go and start with the application. You don't have to complete the application, it's just start with the process. So there are a couple of documents that you have to upload on the ECFMG, like your passport, and there are 6-7 documents, and then you can start uploading them. So if you upload one document over there, you have started the process and you will be in the queue. So after this happens, there are actually 2 categories. One is that if you are an IMG who already has let's say J1 visa, like you were doing research, there's a separate a format, and somebody who doesn't have a J1 visa before, and you are a fresh graduate, you are like somebody who is applying for the J1 visa for the first time. There's a little bit different procedure for that as well. So let's talk about the one. Suppose this is the first time you're applying for a J1 visa. So once you have started the process, like you have filled up the application where your program is going to send you a code, which you have to go and enter in the ECFMG like OSS in your account, your application will open up and you have to start uploading the documents. So once you're done that, there's another column for SON, statement of need, that is to be done by your home country. So I know I'm from India, so I know the procedure, like what all we have to do for India, but I don't know about any other country. So there are different forms which are basically released by different countries. I know Pakistan as well, that you can apply for SON online, and it's a pretty quicker pathway for them. It's like done in 24 hours. But if you're from India, it's not online. You have to submit the papers. So where you can get SON. So you can get SON either from the health ministry website, or it's usually like circulating in the groups, and you'll have your friends who will get it from the seniors. You can get it from them. So there's this SON application has two basically, I would say, parts. One part is for the applicant, and the other part has to be done by the health department. So the first part is called like the applicant application, and there you have to fill in all of your documents and everything. You have to fill in all the, like, where you're from, what's your passport, what's your passport number, your basically your information. So once that is done, if you are in US, then you have to send that first part to the embassy which is near to you, and they will notarize it, because you have to get it notarized. If you're in US, you have to get it done from the US and then send that to India for the second part, which I'm going to talk about. If you're in India, you can just hold on, you can just fill that up and keep it, and we'll talk about the second part. So once that is done, that is to be filled by the applicant. The second part is to be filled by the surety. Like, it's a paper which says that you have, once you are done with your training, you have to come back to your home country, and if you don't come back, you have to pay like a certain amount of money to the health ministry as a fine. So for that, you have to give two sureties. So you can pick, it has to be one family member and one non-family member. So you have to pick that and fill that form. So that form has to be notarized by the ministry. So once you get it notarized, so if you are from, suppose you're applying from US and you already have like a J1 visa, you fill the first part and send it to India, and the second part would be completely filled by like the family member, whosoever is your surety, and they have to notarize it separately. So you have to get it notarized 2 times. But if you are in India, it doesn't matter if you had a J1 visa before or not. It's the same procedure for this one, that you have to fill the form, fill the second part as well, and get it notarized one time, both one time, and then you have to send it to health ministry. That's it. And then you have to wait. Usually health ministry, for me, it took 5 to 6 weeks for them to revert back and upload my SON. So my only advice is that whenever your TPL reach out to you that they have created your account, just start the application, because that's going to put you in queue. So once the SON is processed, if you are an applicant who didn't have any J1 visa before, and this is the first time you're applying for J1 visa, then SON, if it's uploaded by the health ministry, ECFMG will review your application, and you'll get your DS 2019. Then again, once they send you an email that your 2019 has been uploaded. You have to pay ECFMG CVS ID. Once you pay that, they'll release that DS 2019 to your program, and you can reach out to your program. You can reach out to the program, because you can ask for a soft copy of your DS 2019 and apply for interview date. So if your program is agreeable to send you like a soft copy, you will have your ID number, and like you know all the ID, like the DS 2000 number, and you can put that in the interview application, like the visa application, and you can take the date. But if they don't, then you have to wait for at least 5-6 days more for you to receive the form, DS 2019. So once that is there, you have to take your interview. You have to take your interview date, and that also you can do in person or by waiver. I would highly recommend to do in person because I applied in Dropbox, the waiver one, but it took a lot of time. It took another, I think, easily 3 to 4 weeks for my passport to come back because it was, they kind of just took a lot of time. So I would appreciate that go in person and they give visa on the spot, and then within a week you'll get your visa. So this procedure is for those candidates who are applying for the first time for J1 visa. For candidates who already have a J1 visa, so for them the procedure so far till the SON is same. But then what happens is that you have to pay an extra fee to the Department of State, because since you already had a J1 visa before, now there's a change of status. Maybe you were doing research, so your status has been changed from research J1 research scholar to a alien physician. So you have to pay extra fee for that, and then your application will go to Department of State. So once Department of State goes, they take approximately 60 days. That's what it is written over there, but they work pretty efficiently, and usually it's kind of done in I would say 2 to 3 weeks. So once that is done and the Department of State gives a green light to the ECFMG, then ECFMG is going to release your DS 2019. And then the procedure is same. So that's what happens. It's little stressful during that time, but my advice is to just be on the top of the game. Whenever you receive any emails from ECFMG or your program, just revert back as soon as possible and try to submit SON application as soon as possible, because it takes a lot of time for them to review your application. So that's what is that's the procedure after you match and before you start the residency.
So, Pratika, if you can, I know one of the panelists has to go to ICU. Rishabh is in ICU. So, do you mind if he takes over now for talking a bit about FM, and then we can come back?
Yeah, I won't mind it. Definitely,
Okay.
he can
Thank
take
you.
over.
Thank you. Rishabh, I know you are in ICU, so I apologize, but so all yours. You're on mute. Can you unmute?
Yeah. Can you hear me now?
Yes, yes, yes.
Are you hearing your sound back? Because I'm in car and it is connected to Bluetooth.
Oh, you're audible. We can hear you.
Okay. So, hi guys, this is Rishabh Lohi. I'm a FM medicine resident at North Dakota. It is University of North Dakota, School of Medicine and Health Sciences. So I'll be touching upon why I chose family medicine, how does a family medicine residency looks like as a 3-year process, and what are future prospects. So I'm kind of a person who wanted a good work-life balance. So, and beside that, outpatient thing more than inpatient stuff. So in family medicine, you can first of all do more of the outpatient, and you can go from 9 to 5, and then weekends off, and you can have that work-life balance. Second thing that I thought it was a good thing. It was more of outpatient. I could cater a lot of population. It was my choice to start from pediatric to geriatric, whatever population I would like, and I can cater that population. As compared to internal medicine, you need to deal with adult medicine only, even if you are in inpatient, outpatient, whatever it is. So yeah, there was a flexibility here. Second thing was you have a lot of outpatient procedures, which I like to do, and you don't need to be a psychiatrist, but still you can deal with the behavioral health patients. So my interest these days is to do a sleep medicine moving forward, doing also catering with behavioral health patients, not being a psychiatrist, but dealing with them, and also doing some outpatient procedures. So if I talk about how family medicine 3-year residency looks like, you have a vast experience here. You have each month is a new month for you, especially for your first year. You are in ICU, you are in surgery, inpatient, outpatient, everything, because a family medicine at base should know everything. So yeah, so I started with inpatient, then go to pediatrics outpatient, pediatrics inpatient, the surgery outpatient, surgery inpatient. Right now I'm in ICU. I'll be going forward again doing inpatient medicine, nights, everything. You do everything. You touch every part of medicine during family medicine residency. And especially for my program, it is very flexible. They ask you on the first day what your choices are, how you want to proceed with family medicine, because it's a very wide branch. So I told them on the first day I want to do sleep medicine. So then they are very super friendly, helping me getting electives for sleep medicine, whatever anyone else wants to do. They are super friendly in moving forward like that. So someone if want to do only procedures, they will help you getting more procedures. It's like that in our program. So future prospects, there are many future prospects. If sleep medicine can be one, pain medicine can be one, addiction medicine can be one. There is a behavioral health fellowship in future if you want to do. I would not explain it further because there are the data is available online. Everyone can search it. But yeah, as compared to IM, you can't do those gastro, neuro, nephro in family medicine as a fellowship. But you have many future prospects, and family medicine is in a huge demand in United States these days. A myth that I would like to burst here is family medicine is for just EMGs or USIMGs. No, it's not correct. It's all about your profile. It depends upon your profile. If you have a profile oriented to family medicine, you will get interview and you will get match. In my case, I applied to 150 family medicine, 150 internal medicine programs. Because my profile was more of family medicine, I didn't even get a single internal medicine interview. All interviews were from family medicine. Although, according to guidance from Pawan and all USMLE Sathi team, I kept contacting all the family medicine and internal medicine programs. So I was not able to get any internal medicine interview. And I matched in my first cycle, and I am the one who matched with low scores. So if I can do it, everyone else who is in this journey can do it. My best advice will be, don't give up, just keep moving. This journey, the way it is worthwhile in this journey.
Thank you very much, Rishabh, and good luck. I think you have to go to ICU, but appreciate your time you could spend with us.
Yes, thank you for having me. I'm gonna leave now.
Thank you.
You guys can continue. Thank you.
All right, let's move on. Vineet, are you there?
Yes, I'm here.
All right, let me give you, you should have okay, now you should have video access. And
All right.
Vineet also had a, well, I mean, why don't you talk a bit about your profile, because it's, your background is a bit unique.
Right, yes. So, hey everyone, my name is Vineet Lakhala. I'm one of the PGY2 residents at Medical City Arlington in Dallas. I'm from Hyderabad, India, but went to medical school in the UK, and then came here for a gap year when I applied for residencies. So yeah, I don't usually see many students that have gone to the UK, so I have a bit of a unique perspective. I guess in that case, if anyone here is interested and trying to decide between the UK and the US, maybe I can help you with that. You know now, you know, which way I went. I went with the US, and I'm very happy with my choice. You know, some of the big differences between the US and UK is in the US, the starting pay is about 3 times the highest pay you'll ever be paid in the UK, so huge difference. Also, all of my friends who I went to medical school with in the UK, you know, they're still working there, and they're just about 2 or 3 years into like 7, 8, 9-year residency programs. So they're junior doctors for a lot longer, so they don't have as much autonomy as a second year here in internal medicine does. Also, there's a lot of other tests like phlebotomy and cannulas and catheterizations that doctors are expected to do. So the nursing staff, they're not as well trained in all of that. So in that way too, I love being here. I know that here it seems like a lot to work 80 hours a week. My friends in the UK work about 40 to 50 hours a week, but they do a lot more each day, so they're a lot busier. I've been really enjoying internal medicine so far. It's a lot of putting things together, a lot of like detective kind of skills, going over chart reviews and going over lab results and tests and stuff. So I like that aspect of it. I'm not really into procedures, and I like that as a hospitalist, you don't have to, do procedures. I find that USMLE Sarthi did really help me when I first started out because that's how I started with the letters of intent. And I think that was really helpful what you guys did. So I would really suggest that you reach out to different programs. Also, the interview prep that I had was really helpful. Mainly, it's important to just be friendly and smile, and not just talk about your accomplishments and achievements, but in a monotone way. Don't do that. Make sure you actually connect with the resident or whoever's that's interviewing you. Make sure you connect with them in a human way. Work life, I'm looking forward to working as a hospitalist in the future, and I'm looking forward to getting a 7-on, 7-off gig. I like that by having a whole week off, I get to do different things while offices are still open, because I find that if I'm in a regular office kind of job where it's 9 to 5 and I can't go to the bank or do anything because my only days off or weekends off, so that's a big thing. One other thing that I wrote down here for advice would be to save up enough money from the beginning itself. It was a bit of a shock for me to realize that it was $27 per interview application, so per residency spot, and I applied to like 300 spots, so it was a lot of money. So make sure if anyone here is still in medical school, make sure you have a little pot. Maybe you can put up a automatic transfer, save a certain amount of money every day. But yeah, I think that's all my advice. Do you have any questions for me?
No, I'm looking at the chat. If there are, I'll get back to you.
Sounds good.
I think you answered the work-life balance. I think you did answer how to pick between UK and US, and that's an important one. Although we do have a lot of students who have worked in the UK and then they come back into residency in the US. So, but I think you did answer.
And there's a reason why, no one's happy in the UK. It's great for medical school, I know you had some questions too about going to medical school in the UK. I can do a talk on that. I loved it. Amazing experience, but not for actually working there after medical school.
All right. Well, I will be in touch with you because my daughter is considering that. So
I see. Okay. Sounds good.
But thank you very much, Vineet. Appreciate your patience and time today. And if there are questions, I will be in touch looking at the chat.
Sounds good. I can help on the group chat. I need to
Yeah,
go
if you are on the
patients
chat,
now,
then
but
yeah, that will be great. Yes.
All right.
Let's move on. And Sahil, are you there? Sahil Kapoor?
Yes, I'm here.
Okay, thank you. You are the co-host, so you should be able to share your, video or screen, and let's talk about your specialty, your journey, and any tips that you have for the students.
Sure. I think psychiatry, I didn't see anybody here of InPsych, so I would
Yeah,
just...
you are the first. Yeah.
I would say psychiatry is actually a very amazing branch, like every other branches, but it depends on your interest. I think the first thing that everybody wants is to shape your resume and show your genuine interest in every single branch that you can. So for psych, it's the same. People look at your resume. They see if you actually want psych or not. And I think for that, you have to take every single opportunity that comes your way. Sometimes the opportunity is really hard to get because psych, not everybody has hands-on experience in psych. So you can definitely explore options like doing research, putting some experience there, or even doing some interventional psych rotations where if you can. I think that has helped many applicants here in the program, and as well as me as well, because I did a lot of research before joining residency program. For becoming a competitive applicant, I would say fill all the gaps. Everyone works on their scores because everyone wants a better score, and do more research, do more rotations, and also reach outs. Like you can reach out to programs asking about their specific what they want, what they would expect you to have in your application. And also anyone you know in any single program, even if you don't know, you have heard somebody, just reach out to them. You never know what opportunity might open for you. I think I've been doing research. I know you asked about research. So I was doing research earlier. Currently also I'm doing research with my previous mentor, and I'm also doing research with my current mentor. So just like staying active in every single aspect I can. My schedule is mostly like 8 to 5. It's pretty easy. Sometimes you get off easily at like 2, 3 p.m. Depends on the rotation you're on. It's Monday to Friday. If you're in IM, then it's definitely 6 days a week. You get 1 day off. Then it could be a little bit more like if you're on call, it could extend a little bit beyond 5 p.m. But otherwise, it's like pretty easy going, nothing major, nothing stressful. You can definitely pursue your own interests there. You can do research. You can even do some work like volunteership in the community if you want alongside. I think many of us have low scores as well, and we get that question often, like how can we overcome them? You can never overcome them. It's just like you have to accept that your application is weaker on that aspect. Now you have to work on other things. You can reach out to people and see what they have done, but your journey is your journey. You have to make the best out of it. And if you really need some specialty, if you really need a branch, you can always work in that field. You can do research, you can do rotations, develop connections as much as you can, and show that you are actually passionate about that branch. You work extremely hard. I think that can open a lot of doors for you. I think that's the questions I
Well,
have.
a couple of questions. Fellowship or post-residency opportunities.
Right. So
Psychiatry.
fellowships, I think psych fellowships are not competitive enough. Like you can get in them easily. It depends on the program that you're really searching for, but otherwise they're pretty easy to get into. There are some people in the program, who have done fellowship before they joined a program. So you can always follow that path as well, like do an year of fellowship and then pursue your interest towards a residency position. After residency, it's not required for you to do any fellowship. You can go and work for any single position you want. There are many opportunities. You can join the forums. You can see like a lot of opportunities in different area that pop up every single day. I think that's...
All right. No, most important question, salary. People have been texting me, how much salary can I earn?
Well, it will fluctuate. I think it depends on the demand. Currently, I think it's, I was just talking to one of my PGY4s here, and it's like about 300 to 350. That's initial that he's getting, but it depends on what kind of job he wants to do. I think Psych gives us a flexibility that you can do 2 jobs at the same time. You can pick up 1 week off at one job, 1 week off at the other job. So you could technically do more work in the initial few years of working. So you can earn about 450, 500. It depends actually how much you want to earn. You can earn less and enjoy your lifestyle, or you can earn more in the beginning and enjoy the lifestyle later. So it depends.
Okay. Well, thank you very much, Sahil. Appreciate your time.
Thank you.
It was great. And, if you're around, you can answer questions on the chat. Otherwise, thank you very much. I know you are also busy today. So, guys, as you can see, the panelists are working full time. Someone is in ICU, someone is in attending. So we will get to all of them and answer all your questions. Just bear with us. Now let's move on to neurology. Let's see. Yes, Anaga is there. So Anaga, let me see if I gave you access. Okay. Now you should have access to video and audio. So why don't you share your journey? I know you had a very interesting journey so far. So
Yeah.
talk to them about your journey and, why neurology. Before you do that, let me ask a pop quiz question for those of you who are still there. Where did Vineet do his his MBBS, his med school? So Vineet just spoke about IM before Sahil. So yes, it was UK. So you can only win one prize in this. So Swati, take the email. Yes, Anaga, let's go.
Yep, absolutely. Good afternoon, good evening, everyone. Thank you for having me here, Pawan. I'm Anaga. I'm from India. I finished my medical school and residency in India, and I applied for neurology in the US. I think in order to consider neurology, you need to be really interested in this specialty. Every attending, everyone who will interview you will want to know that you're specifically interested in neurology. They will know if you're applying to it as a backup specialty. So make sure you have neurology specific profile with some research experience, observerships dedicated to neurology. It should not be more of IM and less of neurology, then that will make them feel that you're applying to neurology as a backup specialty. Again, have good scores. There is no compromise on good scores and having a complete application. There will be many applicants who will have complete applications. So if you're lagging on some aspect, just make sure to time your application, all your exams, try to complete step 3 before you are applying as well. A day in my life typically would be, neurology is not as hard. There are many fellowship options, so your life can really be inpatient heavy or outpatient heavy, depending on what fellowship you choose. Or if you choose not to do any fellowship, then you would be a hospitalist, or you could also be a general neurologist. That means you could have a life in the clinic, or you could choose to work in the hospital. Some places will allow you to do a hybrid practice. That means some weeks you are on inpatient, some weeks you're in the clinic. Life is usually not as bad except for specialties like neurocritical care and stroke, where there will be a lot of emergencies, even epilepsy. Sometimes they can be managed on the phone for attending level, not for resident level, but these specialties are going to be busy: vascular, stroke, epilepsy. But other specialties like neuromuscular, movement disorders are more of an outpatient based of a lifestyle. So I would say in India, in our internship, probably, or anywhere else where you're from, if you don't have neurology specific exposure, because most of our internships are centered towards all the basic specialties like surgery, obs gynae. So try to get neurology experience, see how it fits you. You need to like the branch that you're applying to. That's really important. And also you need to know what kind of a person you are, what kind of a life you want to lead, and how this branch kind of gels with you as a person, and where do you see yourself? How do you see yourself working, where the family is important for you? So in my journey, I finished neurosurgery in India and then I applied to neurology. So there were a lot of ups and downs that I went through during my application process. Salary ranges. So in terms of red flags, before we go to salary, the red flag for me was older year of graduation. I unfortunately could not complete my step 3 before I applied, but I did make sure that I reached out to all the programs right from July, August. I was emailing, sending out letters of interest, asking for observership opportunities. And I think that really helped me. And I had 16 interviews by the end of the season. So make sure you're reaching out to the programs early on as well. There are a lot of opportunities for me to be involved in research. I was involved in research projects even before. Research is something that will not be published within like a month or 2 if you want something that's a good quality research. Okay, so it takes time for you to reach out to a journal, for them to review the articles that you've sent out. So it will take at least 6 months to 1 year. So the 2 articles that I was working on for 2 years before they actually got published. The time frame may vary for different journals, but usually try to start working on it. Can just be a case report, case series, just something simple. That's also fine. Neurology will require you to have not extensive research, but they would like for you to have at least 3 to 5, minimum 3 around, plus minus 1 or 2 research experiences on your CV. Yeah, as a part of being involved in research in my residency, I think there are a lot of opportunities. There are many attendings who are involved in research. It's up to you how you take initiative and try to find the time despite being busy and try to make sure that, and it's possible, it's not really impossible. Like for neurology, the first year of internal medicine, I think we do almost 8 months of internal medicine inpatient rotations, which can be pretty hectic. But the rest of the 4 months are outpatient rotations, during which you will find ample time. And even during the inpatient rotations, most of the time we are on from 7 a.m. to 5 p.m. So it's still really not that hard to go home, finish your chores, and put in an hour or two of research, maybe 2 or 3 days a week. So it all depends on how much work you put into what your profile is going to look like. Sorry. I did not.
I'm sorry. Can you also talk about work-life balance? You are a mother yourself.
Yeah, absolutely. So definitely the work-life balance right now is much, much better than when I was a neurosurgeon in India. Despite being on inpatient in internal medicine, I still feel like I get to spend more time at home because the schedules are not as crazy and you do tend to get off when you're supposed to. It's 7 to 5. So, and the way our program is structured is we work 8 days, we get 2 days off. So each program is going to be different. Some might be 6 days on, 1 day off. But the work-life balance overall in the US will definitely be better from what it was back home. And I think even though I send my son to daycare, and sometimes some days are really hard, but I still feel that I am able to give him the kind of time. We are also able to go out and do fun things in the city. So I would say that I definitely get more time at home, despite having a heavy week at work. I did not apply to multiple specialties. I had only applied to neurology. So my application was very specific. I applied broadly. If you're applying, putting in your efforts in one match, just go all in. Don't compromise anywhere. I know it's going to be expensive. I had to travel in terms of cost. I wouldn't say my cost would apply to everyone because for my rotations, I had to travel with my son and my mom. So I almost spent twice or thrice as much as what any other person would because the flight tickets were expensive and the Airbnbs had to be bigger and all of that. So be ready to have calculate all your costs and add 25% to that for some additional costs. Tickets are usually going to be 1,000 to 1,500 return in terms of dollars. Your stay might be for each rotation somewhere between $500 to $800 roughly. If you rent a cab, consider those expenses. Minimum cab fares are usually between $7 to $12 one way, or find places that are closer to your rotations that might help. Food will cost you. So there are many additional costs. A cell phone might cost you, like a local network. So consider these costs when you're applying, but don't compromise on, if it's one season that you're applying for, just make sure you apply broadly and have a complete application.
Yeah. Please talk about salary in neurology. This is the favorite question in all specialties.
Okay. Yeah. So salary again, I think like for all other specialties, it will vary from 200, 250 to maybe up to 500, 600, depending on what you do. Higher paid subspecialties in neurology are stroke, vascular, maybe even neurocritical care if you do more procedures. Even as an outpatient, say if you're a neuromuscular specialist, but you're doing procedures, you can again bill for the procedures. Epilepsy, if you read more EEGs, there are EEGs can be read remotely also. So that can again add on to your salary package. So the more skills you add on to your CV, the more you will earn. Generally, I would say on an average, it would be somewhere around 350, plus minus 100, 150.
Well, thank you very much, Anaga. If there are other questions, I'll keep an eye on the chat. But thank you for your time. I know you're also busy with your son.
Yeah.
So
Luckily, he just slept before the first speaker, so I could make it.
Thanks.
Absolutely. Thank you for having me.
Thank you. Let's move on before we get to Taufik in pathology and Salika in pediatrics. I know Arushi and Prabnoor, you've been waiting patiently. So Arushi, did you want to talk something specific in FM? I think you did want to talk something about it. You're on mute, Arushi.
Hi, Pawan. Thank you for having me. So, I just had a couple of more points to add. This is my intern year, and this year I've been reviewing candidates and applications and interviewing them. So, just one point to add that if you're applying for family medicine, you should be having at least 1 or 2 family-specific letters coming out from family medicine practitioners, and the letter should actually stress more upon your personality and how you deal with patients in a real setting. And on top of that, we are also very much focusing on MSPEs and the performance and personal statement. So just make sure that every document that you submit during your application is very well focused on FM. Even in your personal statements, mentioning about obstacles that you have been able to overcome, it makes a difference. And also on the research aspect, my CV was very much heavy on research. I did 1 year of research at University of Louisville, working as a research coordinator. So that was very much appreciated in my program. So whatever publications that you are going to publish, just pick up a more centralized disease that you want to focus on, that works on, if you're applying for multiple specialty, it should work for both of them, because even in FM, we look out for publications that are relevant to our specialty. So that would make a good difference. And then just another advice, be aware of the weaknesses that you have on your application and how to overcome them. There are certain weaknesses that you can't overcome, like scores. If you have already taken it, you can't overcome, but you cannot change it, but you can always overcome with other aspects of your CV. Same goes with your year of graduation. If you're an old graduate, don't be afraid of apply, but work on the other aspects, bring your other aspects on table, strengthen them, and that will help you in overcoming all your weaknesses. Apart from that, I don't think so there is anything that has not been discussed from FM specialty. This is what I wanted to add, and that would be all from my side.
Thank you very much, Arushi. And yes, your perspective as someone who's reviewing the applicants is much appreciated. Thank you.
Yeah, thank you.
Prabhnoor, did you want to add something as an experience in FM? What has been your journey? And just share it with us, please. You've been
Yes,
waiting
hi.
patiently, so.
Yes, hi. I'm Prabhnoor Saraya. I'm a PGY1 intern year at University of North Dakota. So with FM, I think as the previous speaker said, it's because we're on the other side of the table, this side, and this year we were reviewing applications. We were kind of seeing what they're seeing, what the programs really want in the applicants. So it's more of the from at least from the FM side, I think it's more of the personality for them. You really have to be passionate about patient care, and you really have to have a good, as a good human being, you really have to have a good personality. Because I think when we're talking about applicants coming in and when we're reviewing them, what we see is, are they going to gel in? Are they the kinds who will just sit in the corner, mute all day and not participate? Because residency is hectic. So that factor also comes in and chips in. Apart from your intelligence and apart from your scores and everything, this also comes into play really big time. So have a lighthearted personality when you show up. Have a smile on your face every time. And I say this to everybody who comes across. Always have a smile on your face whenever you talk to anybody, and always have confidence in yourself. So that's the only things that I think while I was reviewing applications this time, I kind of those were the 3 things I kind of grasped onto. Apart from that, I wanted to talk about why I chose family medicine as a specialty. So for me, I think I really had a good understanding that I wanted to have a good work-life balance. I do not have kids at this point, but I am getting married in a year and I want to have kids at some point. So I wanted to come home to them and have a good work-life balance. I wanted to give back to the society, to my patients as well, and earn a good living, and also come back and, give them the time. And I really love procedures. I have always loved them, outpatient procedures, Nexaplanon and IUDs and hemorrhoid tag removals and colposcopy and a lot of other stuff. So I was really into that and a lot of outpatient stuff. So that's why I also chose family medicine. I had also done a fellowship in palliative medicine before I joined family medicine. But it was a lovely experience. But I think for me right now, my future scopes would be, yes, I would love to do a fellowship in family medicine, but I'm more aiming towards addiction medicine. So we had addiction medicine rotation during our program, and never in my life I thought that I would be interested in that. Not that it's a bad thing, but it just that it just never crossed my mind. But addiction medicine with the US has a very deep rooted, because we see a lot of people who are in addiction, and it's a ongoing branch that has a lot of scope in the future. So with addiction medicine also, you can have inpatient and outpatient too. So that's one of the approach that I really love. But apart from that, you can be a hospitalist too. There's a hospital medicine fellowship if you're interested in. And I think behavioral health was talked about, pain medicine was talked about. There's obesity medicine, there's lifestyle medicine. There's a lot of stuff that you can cater with your practice as you go. You can also do colonoscopies, all of these preventive health aspects of the procedures that you can do. And that as many procedures as you do, that increases obviously the salary, which is I think the favorite portion of everybody that keeps asking. So whatever procedures you do, if you do colonoscopies more, if you're more involved in procedures, if you're seeing more patients, so that all depends upon, and that adds to the salary as well. So I think those were the other things that I wanted to add. And apart from that, have good family medicine rotations on hand if you really want to match into family medicine, because that is something that really will look into. That do you have that? Because some people don't, they just keep the IM rotations and they kind of switch, or they ask the preceptor to switch the just the wordings or something, but they kind of know that happens. So I mean, just have some family medicine rotations on board before you apply. So yeah.
Oh, very, very pertinent point. Absolutely. I think family medicine does look for a lot of passion and commitment. So
yeah.
Thank you, Prabhu. I know you've been waiting patiently, but very well said. Thank you for your time.
Thank you.
All right, before we move to Tawfiq now about pathology and then Salika in pediatrics, question on pop quiz: what is the home country residency for Anagha Prabhune, who spoke about neurology? If you want to mention it in the chat box, home country residency specialty. Yes, Abhay got the right answer. So Swati, get his email. All right, Tawfiq, are you there? I know you've waited very long.
Yeah, no worries.
Sorry about that.
No worries.
So why don't you introduce yourself and let us know. You've done a long journey now in pathology, so
yeah, I mean it's been a while.
Talk about?
So I graduated from Aleppo University in Syria Medical School, and I did also a clinical pathology training in Syria, like for 3 years before I moved to US. In US, I worked in research as a postdoc in Case Western University, and 2 years in Cleveland Clinic as a researcher. Before I started my residency in North Carolina, Wake Forest in pathology. It's APCP program, anatomical and clinical. So it's 4 years of residency. And then I did 1 extra year, it's fellowship in hematopathology. And that was in Baylor, Houston. And currently I'm basically working as a pathologist, hematopathologist in a private practice group in Seattle. Do you hear me, Pawan? You're here, right? Oh, okay, awesome. So yeah, regarding like if you want to know like how you basically need to get into pathology, first of all, you should really have a genuine interest in it. It's way different than other specialties, as you can tell. Like, we don't really see patients most of the times. I mean, we see sometimes when we perform FNAs, so sometimes we see them, but it's not that common. Most of the time, you are basically working with your tissue, which basically is a patient. So we always value that. When we're looking at tissue, we know there is a patient behind it. We try our best, basically, to give the best care. So it's really important to have a genuine interest in it, because it's kind of different from the other specialties, as you can tell. And basically, when you apply for pathology, you need to show that in your CV, in your personal statement, and especially in your CV. So easily program directors will basically know if you're genuinely interested in the field or not. If they see like, oh, you've done like IM rotations, and then there is one rotation in path, this is not going to basically attract them. So they want to really see that genuine interest in your CV. Like by doing rotations, I didn't really do much rotations in path before I matched. I did a few in Cleveland Clinic, but my research has a lot of was extensive, and I think that helped me part of it. It didn't help being a clinical pathologist in Syria back home, but because they don't really look at your CV back home, they care about what you're doing in US in terms of getting into a program. I got many interviews in path, and I choose North Carolina. So regarding fellowships, I think it's very important also to know what you're interested in path, especially after the first year. And if you're interested in more competitive ones, like such as derm path, it's really good to start in your first year, like talking to mentors and the specialty, because it's very competitive, and you're competing derm residents as well, because both can go into derm path, dermatology residents and pathology residents. So it's kind of, if you're interested in that competitive one, then you go start working on it the first year, or even before you start your residency. But if you're interested in other fields, and you can tell, like I never thought about heme path, but after a couple of years of training in pathology, I found it fits me the best. Lifestyle in pathology, I think it's like in residency, it's a reading residency, basically. It's a lot of reading, a lot of learning. You would feel yourself you're back in school. You feel like you don't know a lot, which is a very interesting feeling, that you feel like you know a lot, but then when you start residency, you feel like, oh no, I don't know anything about pathology. It's really a lot of topics, and especially here in US, they do anatomical and clinical together. Back home, like we do AP on its own, it's 3-4 years, and another 3 years in CP if you want to do it. But here it's together, so you're doing clinical pathology and anatomical pathology and forensic medicine at the same time in 4 years. So it's ton of information you have to grasp in 4 years, and that's why the extra 1 year fellowship become very important, to basically get to know more about one thing that you didn't get to know much. And especially now, every subspecialty in pathology is expanding. Like heme path on its own, it's 1 year even fellowship is probably not enough. You probably need 2 or 3, but you would learn also while you're practicing. You're like, oh, this is I never seen. This is like, you know, so you keep reading even after you finish your training and everything. It's very fascinating how much information now, like these fields expanded, and anyways, so after you choose what you want, your fellowship, you also need to choose the kind of environment you want to practice, like academic versus private. And in pathology, probably because since most of the programs, like 99% of them are and in universities, so it's not community hospitals, so you probably won't get any exposure to what private practice mean in pathology. And until you probably, when you start looking for jobs, it's like, oh, wow, there's a huge difference for sure. So academic, you're going to teach residents. It has more exposure to, medical students and also residents. You teach residents, medical students, whoever rotating. So it has also some kind of, I would say, flexibility at work, more than private. But in academic, you feel like you're, even if you're on vacation, they're going to call you, they're going to bug you, and they're going to ask you questions. But in private, it's more, I would say, once you're done, you're done. You're out for work, you're out for work. You do your job and you go home. I have a good lifestyle balance here. I feel like I start by 10 my work, like, you know, I don't see patient, right? So I can come over whenever I want, as long as I finish my cases within, you know, work hours, and usually finish by 4 or 5. So I feel like it's good work load. In academic, it's kind of similar, but it might be, you might, you know, you have other duties like, you know, teaching and writing research. So the practice is kind of different, more complicated cases in academic. So it might be more fun in that aspect. We consider it more fun when it's more complicated, but it become a headache sometimes when it's more complicated. In private, it's more the, you know, bread and butter pathology, and you get some interesting cases every while, every once in a while. Yeah, but a residency lifestyle, I think it's probably, as I said, it's reading residency. You have to have a plan, studying plan. I would say in the first year, you probably need to survive it just to understand the field and, you know, start to see what's normal, what's not normal, I think. And then when you are in second year, you really need to start reading in depth and have a studying plan to be competent pathologist at the end, and also to pass your boards. Passing the boards is something I think it's not as easy and as other specialties. The reason is because, as I said, you really feel like you don't know much when you start residency. So reading is important in pathology. That's what we call it, reading residency. So you have a plan and revisit that plan and keep going with it until you reach the last year. Don't just study in your fourth year and think that would be fine, because it will put a lot of pressure on you. A lot of topics to read in 1 year is too much. And also, you know, knowing things in advance in training basically will get you the like the benefit of this knowledge. So you learn something and then you see it. That's it will make you feel better about yourself even. And also, I would say yeah, keep like just learn from everybody. Like techs will teach you stuff, your seniors will teach you stuff, your attending will teach you stuff. Take advantage of all the resources in residency, like all the materials you get. You have CAB survey slides, have unknown sessions, you have didactics. You take all the opportunities to learn from it, because it's your time to learn. After that, probably we become difficult, you'll be on your own probably. So it's very good to take advantage of the resources you have in your residency. And yeah, be humble, open-minded, and you'll get there.
Well, thank you very much, Tawfiq. This
Welcome.
was very, very appreciative. Shows your experience, and I think you've answered all the questions that most of the pathology applicants have. So I appreciate your time. Thank you. Thank you.
Have a wonderful day. Have a wonderful day. Good luck, everybody. Good luck.
Thank you. All right. Last but not the least, pediatrics. So Salika, again, you've been waiting. I apologize for the wait, but the floor is all yours. And if you're there, we can go ahead. Thank you for joining.
Hi, everyone. I'm Salika. Thank you for having me. I'm a second-year pediatric resident at Sinai Hospital of Baltimore. I'm an IMG and coming from India. I did my med school from Bija Medical College, Ahmedabad. So I'm just gonna go over like what pediatric residency look like, and I will answer the questions if anyone have more than that. So similar like other specialties, pediatrics is also like 3-year program. We do spend like most of the time in inpatient unit, more like mostly like 10 to 12 months, including like PICU, NICU, ER. We also get like 6 to 7 months of elective time, which is very useful if you are like looking for fellowship options and considering fellowship, so you have time to explore during your second year of residency. Typical day in our life is mainly like, as I said, we spend most of time in our inpatient. So we start our days like 6:30 in the morning during inpatient rotations. It's usually like 6:30 to 7 is like our sign out time. And then before rounds, like we get like couple of hours to prepare for the rounds, then rounds last for like couple of hours. We always have our didactic session for an hour in the afternoon, which lasts from 12 to 1. And then afternoon is usually like pending task, any admission. So it's like 1 to 6:30. And in the evening is also like sign out again at 6:30. So that's a typical day. You also do like some rotations outpatients. So it's a very good work-life balance. Intern year is typically a little hard as usual, like other specialties. But during your second year, you have like more outpatient time, and you can have time to like study and do more other stuff like research. Post-residency options, majority like 50 to 60% resident go into like primary care or the hospitalist job, and the hospitalist is the same like I am, like you have scheduled for like 7 days on, 7 days off, so that's the option. 30 to 40% resident pursue fellowships. So the good thing about being in pediatric fellowships are like they are not that competitive. So if you're interested, you're probably gonna get it and at good university programs. There's few fellowships that are like competitive is like cardiology, GI, pediatric emergency medicine is also one of the competitive specialty because of this schedule, and also NICU and PICU are kind of like well-paid specialties. So those are also competitive fellowships that can be chosen from. Other than that, I really want to touch base on applications and the interview process. In Peds Match, we definitely like look for your interest. Sometimes like program directors are aware that like, oh, pediatrics is taken as like a backup specialty. So your personal statement and your interviews are like the place there where you can show your interest particularly. So don't miss those chances if you're applying for multiple specialties and you want to show that you are also interested in pediatrics. Because this is pediatrics is like more like advocacy and all, so they really want to see that you want to be in this specialty. I personally had like a challenges, like I did not match during my first season. So I want to talk about like low scores of any red flags if you guys have. So don't be motivated by those things. I personally feel like that low scores does not define you. You always like don't lose hope and always work on your CV. Personally, like talking about pediatrics, clinical experience would definitely help you to build up your experience, and program really encourage and look those opportunities if you have like good clinical experience on your CV. Also, I have seen like a few of my friends who ended up matching into the same program where they did observership for a couple of months. So you can like try to get those programs like IMG friendly programs and try to get observership there. So once they know you, your likelihood to match into that program will increase. If you are like planning to get into university programs, then the research definitely would boost up your CV. So you can take that opportunity as well. So yes, definitely like work on your CV. If you have any kind of red flags, don't get demotivated, that I would say. Other than that, I really personally from my personal experiences, I feel like when you are ranking the programs, the most thing you need to look for is like people that you're gonna work for, because you're gonna work with those people for 3 years. I personally feel that your senior resident is very, very important in your program, because during your intern year, you're gonna learn the most from them. You spend most of the time with them. So residents' camaraderie and the supportive like working environment is very important. So while interviewing, like look for those subtle signs like, okay, do I really want to be in this program? So this all small things would be very helpful while you are interviewing. I think that is all I wanted to say. If anyone has any questions, I'm happy to answer.
Yes, I mean, in fact, I've been noting down questions. So I don't know if you answered that one question, neonatology fellowship, how competitive is that? I think that was the first question I saw.
So I think it's competitive, but it's not competitive like IM fellowship that you have to have like so much research and all. So because so it's a well-paid subspecialty, so there are like majority people who pursue fellowship going to neonatology, but it's not that you're not like able to match or anything like that. So definitely like start working from your from first year to build up your CV related to your neonatologist application. Like you can choose the QI project or research project that requires for your residency happen to be in the neonatology. So working from the first day would help you to get into your desired program.
Okay, can you tell us more about how you dealt with the setback of not matching in the first attempt?
I mean, of course, it was like hard when you are not matching, but as I said, like, don't take things like too personally. Like this process is like, I felt that there is some factor of luck also. I had like 7 or 8 interviews and I still did not match. So sometimes like you just don't know the factors why you did not match. And in my second season, I had the same interviews from the same like programs that asked me like, oh, why you did not match. I'm like, I don't know why I did not match. So you like I feel like I wasn't like very open during my interviews that I personally felt. As I have listened to many other panelists who spoke about these things, that okay, you have to like be smiling, you have to ask questions. So those are all very important when you are presenting yourself, and especially like in virtual environment, it is so easy to like stay quiet and like not to ask questions. So what I learned from my personal experience is that okay, be the first person to ask the questions during interviews. Be the first person to like show the interest, like when all the people are like in the common group. So don't be shy and don't be hesitate. Show your confidence during your interviews. That is the one thing I learned from my experience. And the second thing is like you have to build up your CV and showcase that you are interested in the subspecialty. So I tried to like get some research experience while I was working towards my MPH, and then I also did like some clinical experience. I optimized my time. Like I was juggling between so many things at the same time, which is super hard. But like if you make your mind that you want to be somewhere, you can do it. So like definitely it's so challenging, but it's not impossible. So you can always work on your CV.
Thank you. I do have a question, but let's wait. The pop quiz question is, Salika did mention her MBBS college name. So anyone who can get it right will get a discount, and Swati can grab the email. So let's see. Oh, someone did get it. All right. Swati, the first one, I think BJ Medical, Ahmedabad, or BJ Medical, I guess we'll take it. MPhys, thank you. Now, question, Salika, is you did talk about research. So everyone wants to know from every specialty the salary after residency and after fellowship.
So salaries in pediatrics is like so like all over the places. Like if you're in primary care, it can start from like 200 to like in between 300. It depends also like if you work in academics versus what you work in private practice. So in private practice, you can build up more, but like if you're in academics, definitely it's going to be less as usual in other subspecialties. Talking about like a subspecialties, if you do cardiology or GI, which is like more procedural specific subspecialties, you have like more potential to earn more than like in between. Starting range would be like 300K to like you can go up to like 400K as you gain your experience. Yeah, so it depends. And there are some subspecialties like which I did not know until I went into pediatrics, like child abuse, obesity. So those are like you will get like around like 150 to 250 range. So it depends. So in pediatrics, that's why like the fellowship versus primary care is always like a debatable question, because some specialties not get well paid, and you want to like check that if you are investing that 3 years of your life into fellowship, is it gonna get well paid or not? So that is always a question, but some people still end up pursuing fellowship because of their interest and passion towards the subspecialty. So it's always like personal choices, but yeah, it can range from like very wide range.
Well, thank you very much, Salika. I appreciate your time and your patience. You've waited till the end, so I really appreciate it. Thank you. And to everyone, thank you for joining. And Salika, of course, you've been great.
Thank you for having me. Good luck, everyone.
Thank you. And guys, if you have stayed back, now Swati is gonna announce all the winners. If you have stayed back, let her know. So she will reach out to you. So Swati, if you can paste the name of the winners. I think there are 6 winners, I guess. So let's see who all are there. And again, we will have more of such conferences. Subscribe to our Instagram as well as YouTube. So this may go on YouTube, but Instagram, and of course, Swati, we will have a lot of information on our Twitter and LinkedIn as well. So a lot of good information for you to come. You will get a chance to interact with our panelists also. So keep an eye out on all our channels. Of course, there are free rotations. So Swati, maybe you can just get them linked to the free rotations. There are a lot of discounts on our match plans as well. So if you guys are interested in the match plans, there are going to be a lot of discounts. And yes, a big round of applause for our winners from today. Swati is posting their email. So if we missed anything, anyone, let us know. And of course, if you have ideas on how we can make these kind of conferences more interactive, more beneficial for you, let us know. Remember, I mean, there is limited time, so there may be questions that we may not have gotten through. So how do we claim the win? Swati, can you put your email down or something? Or yeah, she will email you. So you can do all that. And like I said, we focus only on the IMG. So, your match is our priority. We do help in rotations, research, a match, interview preparation. In fact, any of you who are interested in SOAP, we will be having a lot of information on SOAP as well. Do you offer radiology or pathology rotations and research? Rotations, yes. Research, most of the research is primary care, IM, FM, neuro, FM, but we can check with our lead researchers. So Swati, maybe you can post the link for Dr. Weissman's research, and we can get back to them. Any other last minute questions that we can answer? And thank you for your patience. I mean, it has been 3 hours. You've all waited patiently. Is there anything else that we can answer? And thank you to Swati and Sejal from my team as well. They've been very, very proactively pushing out information to you and answering your questions. How can an IMG graduate get a SLOE for EM? Is it only for students currently in medical school? No, I think the SLOE is a requirement now, even if you are a graduate. But yeah, let's take these questions. Any other questions later on? Thank you, Swati and Sejal. One of these days, you can be on camera as well. So thank you. I'm gonna be on this, we are keeping the chat on just in case you need the links. You have all our information. There is a contact us page also, and we'll be in touch.
Thank you so much for watching. We hope that video provided valuable insights for your journey. Don't forget to subscribe to our YouTube channel and follow us on Instagram and Twitter. And check out our website for details on how we can guide you to a successful match.